Is Jim on?
He is.
Okay, sorry, I can't
I
see.
am. Hi, Susan.
How are you, Jim?
I'm well, and yourself?
I'm well, thank you.
Nice to see you.
Yeah, nice to see you.
Well, I think we're at the 1 o'clock hour, so I would like to leap in. I'm Michael Mcginnis from the National Academy of Medicine, and it's a pleasure to welcome all of you who are in the meeting and part of the Value Incentives and Systems Action Collaborative, the National Academy of Medicine, and all of you who have joined us by webinar for today's session. The session proves to be a very important one, certainly timely with the state of play in the nation, focusing on the ways in which we can, the urgency of the ways in which we can get more value from our health system investments, both health and healthcare. And that's the devoted focus of this meeting and of the Action Collaborative. And the agenda that has been laid out by our co-chairs, who I'll introduce in just a bit, working with staff is one that gets to the heart of many of the key issues. And so thanks in advance to both of you and to the staff for assembling such a productive agenda, as well as to all of you who are active participants in the field. That includes Jonathan Blum, who is the Deputy Administrator of the Centers for Medicare and Medicaid Services, and you'll hear from Jonathan in just a bit. Thank you for joining us. And what my task today is primarily to give a little bit of background context for the work of the Action Collaborative in the National Academy of Medicine, and then turn it over to our two co-chairs, James Madeira and Susan DeVore. And I'll make a comment about them in just a little bit as well. If we can move to the next slide, what I'd like to do is just give you a little bit of rundown on the umbrella focus of the Leadership Consortium, which is to build a continuous learning health system. The consortium is made up of stakeholders, key stakeholders from around the nation, public and private. Those individuals, several of whom are on the call today, who have the ability and the commitment to work to ensure that we have a health system which is as effective, as efficient, as equitable, and as continuously learning as possible. We have worked for some time together on the notion of building a continuous learning health system that can speed the rate at which we achieve effectiveness, efficiency, and equity. And we've defined the learning health system, the next slide, please, I guess it's on there now, as a system in which science, informatics, incentives, and culture are aligned for continuous improvement, innovation, and equity, with best practices and discovery seamlessly embedded in the delivery process. Individuals and families as active participants in all elements, and new knowledge generated as an integral byproduct of the delivery experience. Now, that's an idealistic concept, but it's also a practically realistic concept technically. What we need to do is to align our institutions and our will to ensure that we achieve what's possible. Next slide, please. The focus of our work in the consortium is collaboration for action, hence the name of this collaborative, the Value Incentives and Systems Action Collaborative. Next slide, please. And the collaboratives that we have underway, in addition to the focus of the Value Incentives and Systems Action Collaborative on incentives, are the Science Collaborative. These are themes that you will recognize from the definition that I just read off. Science is the Evidence Mobilization Action Collaborative, which is focused especially on continuous learning through real-world evidence. On informatics, the Digital Health Action Collaborative, focused on building the digital infrastructure for data as a core utility. And the Culture Inclusion and Equity Action Collaborative, which is focused on full and equitable health engagement for people and communities. It's very clear that these are key issues for engagement. Next slide, please. Hence their anchoring as the core elements of the Leadership Consortium. And each of the collaboratives has certain common elements, a series of networks, organizational networks that we work together with to facilitate progress, a series of anchor principles, a series of key progress indicators, and then an agenda of collaborative projects. So they are very action-oriented collaboratives, if you will. And I'd like to just mention briefly on the next slide some examples of the ways in which in the value, incentives, and systems arena, we have been working to catalyze progress. We have the focus through our work in sector assessments on emerging stronger after COVID-19, priorities for health system transformation, which has worked to identify the failures, if you will, of our response, as well as some of the strengths in the context of the COVID-19 pandemic, in order to ensure that we can look to ways in which we can work for health system-wide improvements and transformation, frankly, in order to ensure that we don't find ourselves with the same kinds of shortfalls that we found on many dimensions during COVID-19. We also have worked, Jonathan, I should mention in the context of your leadership at CMS, with Cmmi on catalyzing innovative health system transformation through a discussion series of the Cmmi opportunities in that respect. And we'll hear a little more about that later. We have worked on vital directions for health and healthcare priorities for 2021, drawing on the insights of the collaborative activities to identify the kinds of compelling priorities in financing for stimulating progress towards effectiveness, efficiency, and equity in health and healthcare. And then finally, we are focused especially on the issue of collaboration between healthcare and public health in a transformed health system that engages effectively both the healthcare and the health dimensions. So that's just a quick snapshot of the kinds of things that the collaborative has worked on in the recent months. We've just, I should mention, also come off a series of conversations on how we move to more integrated payments in order to accelerate progress across the board. And by integrated payments, the focus was on not just ways in which we can streamline the ways in which funds flow in order to enhance the outcomes in our health system, but also ensure the way in which care can and payments for care can reward more integrated care in the process. So stay tuned for more work from the collaborative and the follow-ups on that dimension. And I should mention as well that the National Academies has just completed a consensus study on the issue of primary care in the nation, the future of primary care, including underscoring some of the important financial implications of our commitment to better primary care. So the context within which we're meeting today is robust. robust in terms of motivation, robust in terms of knowledge, and robust in terms of will to act. And we're going to focus today on ways in which we might capture that will and channel it into effective action. I want to give special thanks as I turn the meeting over to Dr. Madera and Susan DeVore for their leadership throughout this set of activities. And I want to give special thanks to Susan DeVore, who is advisor and former CEO at Premier, because this is Susan's final meeting as co-chair of the collaborative. She has stepped down as the head of Premier. And I want to note that Susan has been the co-chair of the Value Incentives and Systems Action Collaborative since its inception. And she's made really countless contributions to the collaborative and the consortium as a whole. Her leadership both at Premier and at the academies has helped to usher a new era of transformative progress led by her organizational engagements. And the contributions that she's made, we want to make sure, not as if we have to make sure, because she'll make sure herself, but we want to make sure that we continue to capture her energies and creativity as she, even as she moves out of the co-chair role for our Action Collaborative, because Susan is a very special force on which we want to continue to draw. And at this moment, as I hand the
here's what's going on. The AP released a poll recently that says
as I hand the meeting over to the chair, let me next slide, please, present virtually this certificate to Susan of appreciation from the National Academy of Medicine for guiding leadership, wisdom, and commitment and service to the Leadership Consortium, the National Academy of Medicine, in the field of health and medicine. So Susan, thank you very much for your leadership, and it will certainly be to be continued. Having said that, let me now turn it over to Susan.
Yeah, so thank you, Michael and Jim and the whole team. It's been a wonderful experience working on these various collaborative projects together. After over 40 years in healthcare, I have decided to retire. I'll be doing some other things. Very excited about my retirement. But I have thoroughly enjoyed this, and I think that the work of the National Academy and the work of this collaborative is so important. And I think, you know, the last 15 months through COVID, as Michael said, really showed us where some of our strengths and weaknesses are. And even with the weaknesses, I couldn't really be more proud of the performance of the healthcare system. I mean, what we did to get a vaccine developed, what the frontline workers did to take care of patients, what the supply chain organizations like Premier and others did. You know, I just think lots of heroes over the last 15 months, and proud to be part of this group and proud to be part of the healthcare system as we all have lived and continue to live through COVID. Michael and I got to catch up a few weeks ago, and we had a lot of conversation about, okay, so now how do we get back on track with value-based payment models? How do we get health systems truly engaged and to the table? How do we accelerate the adoption of these new payment models and care delivery systems? And so I think, you know, as Michael highlighted, lots and lots of work to do for this collaborative and the others. I'm going to miss you, Jim. I'm going to miss you, Michael. Going to miss all the participants. And I just thank you for allowing me to be a part of it. So I wish you all the best. And I know you'll do great work going forward. Thank you.
Thank you, Susan. Jim.
Well, let me go over the goals of the webinar, but before doing that, I just wanted to state in saying goodbye to Susan, just from this venue at least, that the combination that you showed of intelligence and insight. And then on top of it, just being a wonderful colleague to interact with, will be truly missed. You were fantastic.
Oh, thank you. You too.
So let me turn now to the overall goal of the webinar, which is exploring the translation of strategic insights from the various initiatives that Michael laid out into actionable approaches for accelerating movement away from fee-for-service toward integrated payment strategies and identification of incentives that best align resources for value and health, leveraging the key lessons for accelerated transformation and identifying pathways for action. So you'll see on this slide the agenda today. We will soon hear from CMS Principal Deputy Administrator Jonathan Bloom on CMS's plans for the coming year and new value-based payment initiatives. We're then going to review findings from the clinicians and professional societies, the care systems, and the health payers' COVID-19 sector impact assessments, focusing on cross-cutting observations and opportunities that were identified to accelerate the value in population health. Following this, we'll discuss strategy, synergy, and opportunities for innovation and transformation of the health financing approaches identified by the Leadership Consortium's Health Financing Workshop Series and catalyzing innovation health system transformation discussion in support of Cmmi. And we'll wrap up the action element with practical lessons, discussing how we operationalize and strategies that have been identified so we can accelerate this transformational movement that we've discussed. So just a couple of topics on the logistics of the meeting. I think we have a slide outlining that perhaps, but we ask the speakers that you turn your video on when speaking, and please remember to keep yourself muted when you are not speaking. And if time permits, we're interested in receiving audience comments, questions, and suggestions. And if you're watching, if you can type in feedback to the Q&A located in the controls at the bottom of your screen on the Zoom platform, seen here. And just please, if you could include your name, your organization, and who the point is directed to. So now, starting with our first session, which is our keynote presentation around moving to value. You know, the context for the present need of this work, particularly with additional constraints on health delivery and financing, as shown by the pandemic, health inequities were showcased throughout the pandemic, and US life expectancy plummeted, particularly along racial lines. In conjunction with that, providers and health systems utilizing fee-for-service financing models experienced major financial shortfalls throughout the pandemic. And that indicates a critical need for accelerated transformation towards financing models that reward better health and reward well-being for Americans, especially in the face of a public health crisis. So in this session, we'll have the chance to hear from Deputy Principal Administrator at CMS on plans for the coming year and new value-based payment initiatives. Jonathan Bloom is the Principal Deputy Administrator for CMS. He recently held the position of Vice President at Health Management Associates. Before that, he was Executive Vice President, Medical Affairs for Care First Blue Cross Blue Shield. Prior to his work there, John served as a senior leadership team at CMS from 2009 to 2014. And as director of the Center for Medicare and principal deputy administrator during that time. He led the CMS's payment and delivery reform strategies and oversaw the Medicare program's policy and management. He recently has served on several nonprofit boards and healthcare policy advisory committees, including Mary Center, which is a DC and Maryland-based FQHC. Also the Primary Care Coalition of Montgomery County and the Medicare Rights Center. John was a critical member of the Biden-Harris administration transition team for CMS. He earned a Master in Public Health from the Kennedy School of Government at Harvard and a Bachelor of Arts from University of Pennsylvania. So we'd like to, just like to facilitate a conversation with John around the mission and upcoming activities that we can expect from CMS. So John, first of all, welcome and thank you for joining us.
Thank you for having me.
And I just ask you to outline your view that how CMS's role in helping the healthcare system move forward?
Sure. Thank you for the opportunity. So great to see so many friends here, and it's great to be here today. I think the one point that I really want to kind of talk about today is that CMS sees the whole work that we do, whether it's
John, you somehow got muted.
sorry, that really has to feed to a common theme, to a common workflow. And I think for too long, the Innovation Center really has been sort of the conversation starter. And that will continue to be where CMS really thinks about kind of payment reform, the large bets we want to make. But I think one of the things that we really want to come back to is that work really has to inform the core programs that that CMS runs. I think for too long, there have been silos. And so our work really going forward, really more on the operation side than the kind of overall policy kind of vision side, is to ensure that we have really good kind of continuity kind of flowing through through CMS programs, that providers can really see the pathway for how they participate. They can see the connections. They can see what we're testing, and how those tests will feed back to core core programs. I think going forward, what you will see from CMS is a kind of much stronger vision, more clear direction, and really strong continuity for how healthcare providers think about CMS. One being a very strong partner, a very strong collaborator, and much clearer for how we think about this journey ahead for us.
Thanks, John. I mean, how do you see that playing out in terms of the primary priorities for innovation in CMMI?
Yes. Well, I think here is, kind of one example. We have the shared savings program. That's really part of the core Medicare program that serves probably 15 million current Medicare beneficiaries. We also have close to 30 million or so beneficiaries that choose private plans to get their Medicare coverage. We have the innovation models that are really designed to kind of test the overall next journey for how we think about total cost of care, for example. I think what we have to do better on is to ensure that all the different ways that CMS beneficiaries and really all U.S. healthcare patients get the same care experience. So if they're getting care from the fee-for-service Medicare program, from their state Medicaid programs, from a private health plan, through more traditional Medicare programs, for example, that we set the same standards, that we set the same goals. And I think we have probably lost some steps in thinking more about the payment model and kind of less about kind of what the overall goal is, what the overall kind of vision is, and really setting the kind of beneficiary care experience being sort of the kind of goal going forward. And I think, you know, payment models and thinking about shared risk, whether it's one-sided, two-sided, capitated, those are really kind of means to an end. And I think looking back, we probably focused too much on trying to design what the model should be and kind of less about kind of what the goal should be. And I think what you're going to hear from our team going forward is really to kind of set that goal that can really be the kind of galvanizing sort of themes that kind of all CMS programs, and we hope all kind of healthcare systems can see, can agree with, and can really point to the same direction. So I think we'll still have to think about the payment models. We'll still have to think about how to set quality programs. We'll still have to think about the attribution for how we count kind of who's in these programs. We're really going to focus first foremost on what's the overall goals that we have, focused on, to the point raised before, much better patient care, much better patient health, closing healthcare kind of gaps, closing disparities, and to really set that first, but then to make sure that all of our programs that we operate here within CMS really point to the same direction and really kind of use the Innovation Center as the engine for testing. So we're clear for how we're going to test. We're clear for what the hypothesis is. We're also clear with the data experience and to feed that back to the world and be clear about what we're trying to accomplish to better inform kind of base CMS policy. And so one of the things that we've talked about is kind of what is the ultimate goal for these models. And we think the ultimate goal is, first and foremost, better patient experience, but to really inform how we set Medicare policy, and how the agency sets state Medicaid policy, and really create that more consistent theme, more consistent pathway for how we build better partnership, build better conversation, build better shared learnings, and really kind of focus on kind of what is the end state that we're driving for, be clear to what is the current state, and be clear for how we're going to use various levers to achieve that goal state that gets defined.
John, you mentioned that, you sort of looking back over the recent past, a learning was to shift perhaps a little bit from the structure of the model to the ultimate goal, make sure you get to that goal. Similarly, looking through the work of Cmmi over the last 10 years, are there learnings from Cmmi that you think we can apply going forward, and how would you think about that in a prioritized way?
I think kind of looking back, and I've really had a chance to talk to former colleagues, talk to current colleagues, look at the past literature. And I think some themes really come out that have been certainly talked about by others, but I think probably still still hold true today. I think there is a general concern that CMS currently operates too many models. I think the team really is kind of working hard to decide kind of what models work, which models should get stopped, which models may not have achieved kind of full goal, but have some really critical key learnings that can get fed back to our kind of more national programs. So that process now continues. I think lesson number one for the future is, and not faulting the past, there has been great work that was done, but going forward, really to be clear, to ensure that we have a kind of much narrow kind of overall kind of model model of numbers to ensure that we have clear direction for our goals, for our kind of overall direction, and for how those that can choose to join us. The second goal is really from an operational standpoint is that we can do far better to share data. And we have the formal process that we hire contracts, bring in contractors to do the evaluation, but we want to do much more shared learning going forward. That means to us, we want to share data. We want to really ensure that that all participants kind of know the experience. They can help build better CMS policy, but also really build better private policies. Third is the portfolio was probably more balanced towards the Medicare program. I think going forward, we want to think hard for how we can bring the same innovation, the same kind of flexibilities to our state Medicaid programs. And I think you'll see much more emphasis on how we really kind of shift kind of more kind of thought process towards the state Medicaid programs. And fourth, I think really going to the first theme is that that we can do a far better job to really build models of care that close for too long the healthcare disparities, for care, for access, for quality. And I think you'll see much more conscious kind of program design to really address those healthcare disparities.
Thanks, John. Before going to some reactors, let me just ask if you'd be willing to give sort of a personal view of in your role as Chief Operating Officer and the Principal Deputy Secretary, where are you going to spend your time? Where are you going to focus? Where will your hands be?
Yeah. Well, we have phenomenal center directors. Two started this week. We have Liz Fowler that's doing a fantastic job running the Center for Innovation. So we are going to, I think from my standpoint, is the goal is to that first point, to ensure that we have one CMS voice, to ensure that when somebody sees what CMS's kind of overall goals are, they hear kind of one vision. What we do on the Center for Medicare side really aligns and kind of feeds into what we're trying to achieve through the Innovation Center, through our state kind of Medicaid strategies. And I think that kind of one job that I have is to ensure that we have one voice, we have one vision. That's step number one. Kind of step number two, I think, is that when we think about innovation, there's the overall payment model, but there's more of the kind of transactions. How do we process claims? How do we collect quality data? How do we calculate the overall measures? And I think we want to use the Innovation Center not just to kind of test the kind of payment model, but test how we think about healthcare kind of working better. The Innovation Center, not to kind of huge fanfare, but still very important, currently runs models that test ways to kind of run prior authorization systems through the Medicare program. They produce huge savings. things. And so it's not just the payment model that matters to us, but it's how we kind of use the operations, how we change payments, kind of build the transactions, how we create data sets that get shared. Those things really happen kind of more behind the scenes. And part of my job is to kind of make sure that when CMS operates, we test not just the payment, but we test better ways to ensure that first and foremost, that our beneficiaries have a kind of much simpler kind of care process, that our partners can get a different experience. And so I think how we think about innovation is not just the payment side, but also how we think about the kind of payment systems, the quality measures, how beneficiaries get better customer service. And so we're going to use the innovation authorities, not just to test payment. That's very important. But as important is the overall transactions, the care experience, how people interact with CMS. That's also going to get tested. That will kind of show us how to be a kind of better steward, how to be a much better partner, but also how to really serve current beneficiaries, Medicare, Medicaid, in a much better way.
Well, that's a terrific and sweeping overview of what we can expect. Thank you.
Thank you.
We have 3 reactors, after which you may have some comments.
Sure.
Again, Jonathan. Ruth Christopolsky from Atrium is our first reactor, and hopefully the reactors will all take 2 or 3 minutes and give their comments and takes. Ruth?
Thanks, Jim, and thanks for having me today. You know, involvement in value-based models has served as the foundation to our population health work at Atrium Health. Participation in these models has provided access to broader data sets that have allowed additional insight into our patient populations. Understanding where, when, and how our patients are accessing and receiving care has allowed us to develop thoughtful programs and services. Examples during the pandemic include using testing data to understand access gaps across our communities and resulted in deployment of mobile testing and vaccine units into our neighborhoods. Access to data has also allowed us to risk stratify patients that has resulted in the ability to focus resources on those that need our help the most. This includes programming around interventions for our highest ED and inpatient populations. And these interventions, including multidisciplinary team rounding, have resulted in year-over-year declines in cost and usage by nearly 30 and 40% respectively. Understanding the barriers to access care and services needed allow us to address the multitude of issues facing our patients. The data provided by our participation in value-based programs is essential in our ability to measure and monitor our progress and the value of the interventions we've developed. Atrium Health utilized the benefits of entering the CMS MSSP program and the APM framework to develop our work in the social drivers of health space. While much emphasis has been placed in this area over the years, the financial structure provided potential funding for the implementation of technology and personnel to support social drivers of health screening and referral programs. Thus far, we have facilitated over 4,000 e-referrals connecting more than 15,000 patients across nearly 1,700 community organizations. This work continues to further integrate screening and displaying results in our clinicians' daily workflows, allowing us to continue to connect patients to much needed resources. We've also utilized the data gathered from these programs to support our social impact strategy. Our goal to eradicate the disparity in mortality across all members of our community, beginning with addressing disparities in diabetes and hypertension, could only be accomplished by access to data provided by our participation in value-based models. We fully support CMS focusing on the experience of our patients and a smaller number of models with clear pathways that have a continued focus on removing regulatory and legal barriers, improving the patient experience, and allow us to be creative and flexible while we improve the value of the care to each individual person. We would also fully support using current models to begin to collect data to define opportunities in addressing health disparities and improving equity. Incentivizing collection of race, ethnicity, and other data as part of the current measure sets and submissions would begin to provide foundational areas to look across broad populations and geographies as identified by Jonathan. Finally, adding incentives to screen and collect social drivers of health information now will provide needed information for development of future models. Thank you for the opportunity to speak today.
Thank you, Ruth. Our second reactor is Jeffrey Brenner from the Jewish Board of Family and Children's Services. Jeffrey.
Great, thank you very much. Jonathan, first of all, thank you for your service. Going back into government is a really big deal, and you know, I really appreciate the work that you're doing. It's a hard job. The piece I really liked about your comments is this idea of moving back to goals and vision. And I think over and over, we make these conversations incredibly technocratic. And what that does is it serves to push lay people out of the discussion. And I think in the end, that causes a lot of damage, because ultimately, this is a discussion, or should be a discussion, about what does good care look like? And as a society, how do we want to use our precious resources to achieve a good life? And as long as we keep making this a very detailed and technocratic discussion, then I think it pushes us away from this discussion. And a very good example of that is a lot of energy went into the SGR, Sustainable Growth Rate. It's a technocratically brilliant solution, and it failed utterly. And every year Congress did the patch on it. And I think it's an example of saying, like, what's our goal? What are we trying to accomplish? What does a good life and what does good care look like? And there are actually a lot of different ways of paying for good care. And I think we have fetishized these highly complicated, very sophisticated ideas that look great on paper, and then in reality are hard to administer. So another example is value-based payment. I worked inside of United for a number of years. I was in lots of these discussions. I've been excited my whole career about value-based payment. But in reality, it's incredibly hard to administer. And because of the fragmentation of our multi-payer system, most providers and hospitals don't have a payer large enough at this point to drive this. And it's hard to respond to signals from many, many, many different payers that are often in conflict. So I think, you know, value-based payment may go the same way the SGR did, which is great idea. You know, like, you could absolutely convince me it's the best idea in the world. You could find examples where it really worked. But the truth is, the provider groups and hospital groups that really jumped on board and took advantage of value-based payment were already amazing organizations who already had deep values in their organization and wanted to deliver good care. And this just accelerated their approach to good care. So I'm worried about the continued increase in complexity will just make all of these ideas almost impossible to administer. So we now have more than half of Medicare recipients in Medicare Advantage, with many, many, many different companies carved up into many geographic units. Each geographic unit is allowed to have their own approach. We've got fee-for-service Medicare, fragmentation Medicaid, a very complex commercial system. Even if CMS did the most incredible job in the world, at this point, the complexity of a society that doesn't agree on what its goals are, doesn't agree on what a good life looks like, doesn't agree on the kind of ethical and moral framework we want healthcare to deliver it within, and has incredible fragmentation on the delivery, is going to have a really, really hard time pulling technocratic levers to improve care, access, quality, and experience. And I'm worried that when we get really smart people in the room, we go really down to all of these incredibly detailed things. And we do need to spend some time up at the highest levels and say, is a multi-payer and I'm not an advocate, I'm not advocating for single payer, but it's a legitimate discussion to say, what is a good life? What is good care? And will any of these technocratic solutions ever work in such a complex society with so many multiple payers? And if not, it is possible to make fee-for-service work. You could actually tweak the fee-for-service model system to get better care. And there are many, many examples where CMS has tweaked the fee-for-service system or stopped paying for a code or did an edit that resulted in dramatically better care. And it's so dumb and boring, no one even talks about it. So I'm an advocate for an honest dialogue that talks about good care and advocates for simple solutions, because every time in my career I've watched a complex solution roll out, it just spins and spins and spins for years. Thank you.
Really interesting. Thank you, Jeffrey. And our third reactor is Victor Wu from Tenncare.
Great. Thanks for the opportunity to be here as well, and appreciate the comments, Jonathan. I think you've outlined some pieces that I'm really excited to hear about and maybe to offer some thoughts on here quickly. I think one of the things that we continue to hear, many people have used the phrase, you want to provide the right care at the right time, at the right setting, at the right cost. And it's kind of a summation of value-based payment. And certainly, I think what you mentioned about the patient experience is really core to how we continue to improve. But a lot of that centers around ultimately of use of the healthcare system. And so, yes, absolutely having a consistent patient experience for the chronic super utilizers, as I hear about Ruth talking about ED utilizers or frequent flyers, all those types of phrases have been used, very valuable. But yet, as we learn and see more, especially in our experience here at the Medicaid level in Tennessee, a lot of the disparities live so starkly in those that never utilize the healthcare system or that are chronically late utilizers of the healthcare system. And so how does value-based payment begin to push our health systems, our community organizations to really identify beyond just reducing variation in care, smoothing out the patient experience for those that are utilizing? How do we begin to do better for the chronic non-utilizers of healthcare or the chronic late utilizers of healthcare in a way that still drives value, but really does require use of service and increased services for an appropriate settings? And so that's an area where I was really excited to hear that, from a Cmmi perspective, but also from a CMS perspective overall, that Medicaid will continue to be a focus. One of the challenges that I think is unique to states, in addition to this larger challenge of trying to cover the entire spectrum of utilizers from frequent utilizers to non-utilizers, is the long-term budget impact for value-based payments, whether that's a payment lever or a payment model design or even just the goals of care, take many years to realize, and oftentimes will take infrastructure development and investment. And from a state budget perspective, which has a yearly pressure, to have CMS come in and provide support that smooths out those early experiences, that provides some budget stability in a place where every organization probably faces annual pressures on budgets, will allow us, I think, to become even more innovative and become even more committed to the long-term goals of value-based payment and the transformation required that really helps to bring out that patient experience to life. And the last thing I might mention is I'm really excited as well to hear about the support from a technical perspective. A lot of this stuff, building on what Dr. Brenner just mentioned, there are still really big gaps from a technical place. So as you talked about boring things like how to process payments better, how you get quality measures from a data perspective, those are really core to the operators on the ground at the state level, at the healthcare level, and even hearing about some of the social risk factors, social drivers, as we begin to embark on that journey of trying to identify social risk factors, so we can better engage our non-utilizers, which we think are oftentimes a proxy through social risk factors. We understand there's so many technical limitations still to have a common language to even begin to focus on that goal. So I'm really excited to hear that that might be a lever. Maybe feeing the right service is actually a good way to go, as opposed to just going straight to value-based payment in some of the social risk factor space. But as you continue to think about that and show leadership at the federal level, we're really excited to be partners and to think about how we can begin to continue using the blocking and tackling in a way that drives to the right patient outcome, not just to drive toward the right payment model. So excited to hear that, eager to learn more, and would continue to kind of encourage all of us to think about how those disparities come to play out in those people that are never utilizing the healthcare system, or that come into the healthcare system at a significantly late period of their clinical journey, of where we've missed opportunities to really improve their health and their health experience. So thanks for the opportunity to offer those thoughts, and appreciate the comments from Jonathan today.
Thanks, Victor. What a great set of interesting comments. We don't want to get too far behind for the next agenda item, but it would seem wrong not to give Jonathan a minute or two to see if these reactions trigger some additional thoughts. Jonathan?
No, I think they're all great comments. I think it just kind of underscores that CMS needs to honor the overall commitment to really spend time with kind of multiple audiences, really to hear perspective, help us define what those goals should be, what's the better care, better life that Jeff talked about, really help us define kind of what are the pain points that we need to focus, more testing, kind of more innovation. Part of my job is to kind of hear complaints. And so if you hear CMS saying one thing over here, something else over there, want to hear those and kind of really want to help kind of reconcile those. So that folks hear kind of one CMS vision, they hear one CMS process, really understand the opportunities to engage, and they really kind of help us define kind of what is better care, better life, and that's our really shared commitment going forward. Thank you for the opportunity. Thank you for the feedback, and look forward to the continued dialogue.
John, thank you. Thank you for taking the time and sharing your overview of the future for CMS. And I want to thank Ruth and Jeff and Victor as well for the reactions. Really interesting conversation. Moving to the next agenda item, the themes for COVID-19 sectoral impact assessments. Michael, I turn it back to you.
Thank you very much, Jim, and thanks to Jonathan and our reactor panel for a very interesting, illuminating, and important conversation about the future of our healthcare system. To me, in listening to it and taking the clue to keep things as simple as possible, I heard a couple of overarching emphases. One is to focus on system performance, that is to say, identify a core set of simple, understandable measures that will give a good sense of how the system is performing. And two, make sure that your incentives are focusing on those key outcomes, while also ensuring that the tracking is careful enough to ensure that people don't fall through the cracks. I guess the third element was, how do we align the incentives among different payers? As Jonathan in particular mentioned, with multiple payers involved, there's a clear need for alignment. But more on that throughout the course of the rest of the conversation. Again, thanks to all, and we're now going to turn to a very important related topic, and that is what we learned from the COVID-19 pandemic about the challenges and opportunities with our financing system. And we have three wonderful speakers to join us and share the insights that they and their teams, and I'll explain what teams mean in just a second, have identified in the course of the work over the last year on COVID-19 impact assessments. We're going to hear from Suzanne Miyamoto, Bruce Siegel, and Rahul Rajkumar, who will each speak for about 8 minutes, and then we'll have some pre-identified reactors to, again, as in the previous session, offer some comments. I'm just going to give about 2 minutes of brief orientation to all of us on what we're talking about when we're referring to the sector assessments. Next slide, please. We see here in this wheel, oriented as kind of pieces of a puzzle, to indicate that our health system is made up clearly of multiple important components, as is our leadership consortium, I should say, the leaders of these multiple system components, and they work and interact in interlocking fashion to determine how our system is performing overall. And we marshaled the leadership of our leadership consortium at the outset of the pandemic to pull together teams to assess the impact in real time, if you will, of the pandemic on the system's each of the sector capacities and the challenges that they faced. The 9 sectors that were part of the analytic process included clinicians, patients, families, and communities, care systems, healthcare payers, public health, quality, safety, and standards organizations, digital health, health product innovators and manufacturers, and research. So we had teams of lead authors and cooperating authors from these various sectors looking carefully at the state of play and drawing conclusions. And we're going to focus today on the particular element of the financing implications and the changes that might be indicated as that sector, while there was a dedicated focus on payers and financing, really impacted each of the sectors. Next slide, please. Here's just a quick rundown of the way the activities were structured, indicating for each of the sectors that you see down in the left column, the lead authors involved are not indicated by name, but by the positions they hold. Hence the roles that they play in marshaling all of the sector resources in this analytic process. As I indicated, a key theme that undergird many of these assessments has been the need for adjusting incentives to prioritize equity, alignment, and innovation. And now I'm going to turn to our 3 speakers to hear about findings from the clinicians and professional societies. And there we'll hear from Suzanne Miyamoto, who is the CEO of the American Academy of Nursing and a leader in the clinicians and professional society sector. From the care systems, and here we'll hear from Bruce Siegel, who is the president and CEO of America's Essential Hospitals and leader in the care system sector assessment, and in the sector assessment for health payers. And there we'll hear from Rahul Rajkumar, who is the Chief Operating Officer of Optum Care Solutions and a leader in the health payers sector assessment. So again, thanks to each of you, and let me turn the floor over to Suzanne.
Well, thank you so much, Michael, and it's a pleasure to be here today. This was an incredible process to work with Jim Madera, who's on the call today, working on the clinicians and professional society sector, and the incredible team of experts from multiple disciplines, multiple expertise, as well as the NAM staff that helped move this process forward. And I think as we reflect on clinicians and professional societies, it's that time to reflect on, too, the tremendous progress that has been made. And there is a need at the same time to remain diligent as we see cases of the Delta variant rising in different corners across the country. At the same time, we're seeing heightened engagement and efforts to spur vaccination in communities that we know have not hit those vaccination rates, and they're really at the forefront. So as we consider the clinician workforce, there is this underlying tension and current, if you think about it that way, as providers wait and anticipate more people to be coming into the healthcare system if these cases continue to rise in those areas where low vaccinations are, and in rural communities in particular. And the trend in this balance of being able to reflect on the progress that's been made will really help guide this step. And this was a really fantastic process, and really from the perspective of looking at different assessment areas of the pandemic to be able to trend the progress forward so that we have more of a guidepost as we see these cases rise, or if other scenarios play out over the course of the coming days. So as I think about the challenges, which was the first opportunity that we wanted to think about, there were a number of challenges. And I think in the clinicians and professional societies, the first one that was at the forefront was occupational distress. And clinicians were already experiencing stressors on a daily basis. And we know that the clinician well-being is so critically important to making sure that we have a workforce that can care for the patients, families, and communities that they serve. But COVID was an acute stressor that put a substantial amount of physical, emotional, and moral toll on that workforce. We know that while they were balancing work, they were also trying to protect their families, they were trying to inform their patients, their communities, and all at the same time, science was being challenged, misinformation was being out in the public, and they were trying to control in their day-to-day work and life how to help move the needle forward. It really was an acute stressor. And I think that clinicians had to carry on in providing that core and critical care as changes to the pandemic hit across the country. The other challenge that really came into play early on in the pandemic and then morphed over time was the staffing, operations, and the financial impacts. And as I think about staffing, we know that as cases rose, healthcare systems had to redeploy their clinicians. So there in our profession in nursing, there were nurses that were pulled into COVID units or into acute care, same with other colleagues in the health professions workforce that were pulled in to support the care that needed to be delivered to the increased trend in the number of COVID patients. So a lot of professional societies were core to helping ensure that they had the educational training they need to be able to provide this care. But again, it was a huge challenge in the pandemic to make sure that we could, and healthcare systems could have the providers they needed, where they needed, when they needed, to the colleague that spoke earlier about that right care, right time, right place. So there was a lot of movement to make sure that was being taken care of. This also required this rapid information exchange, and how could we get that information out in the systems that needed it. And so really wanting to make sure that key public health data was communicated, that also served as a challenge when those channels for communications were not as strong. One of the other things related to the financial impact, as we know, was those revenue shortfalls, because a lot of procedures or care delays were put on hold in the pandemic. So again, under that fee-for-service reimbursement system that Jonathan Bloom talked about earlier, looking at CMS, how are we going to address that in the future? It really was highlighted as a challenge during the pandemic. And I think from the educational disruptions, we know that as the pandemic emerged in March, April, May, we started to have this uncertainty about how are we going to graduate clinicians. The clinical trainings were being disrupted, clinicals were being canceled. There was this pause and a re-emergence of how are we going to make sure those things move forward. There were hiring freezes, research projects were put on hold to place the priority on the pandemic. And I think one of the things that the pandemic further highlighted was the need of the educational system to make sure that we address the inequities that further came to light over the course of 2020 and the longstanding effects of structural racism and social justice issues within our healthcare system, within our educational system, and the need to address this moving forward. So a lot of disproportional communities and students were being impacted for various reasons, from financial or the toll that it was taking in their own communities where they were experiencing these delays in their education or holds. So a lot of challenges making sure that we moved forward with the providers. But through all of those challenges, as we want to discuss, there were a number of bright spots. And so as we think about those bright spots, which are outlined on our next slide, we have this really important and powerful moment of clinician advocacy. Clinicians became a trusted messenger, as they always were, but even heightened. They were in their communities. They were advocating for inequities they saw in their own communities, what their patients were experiencing. They were making sure families could connect with patients, whether it be on a national or individual advocacy. They were really put at the forefront. At the same time, they were advocating for their own wellness, as we saw the challenges of PPP shortages over the course of the pandemic. So clinicians really raised their voice as they experienced this own acute stress from the pandemic. The other bright spot was a nimbleness to rapidly respond to making sure information was communicated. So professional societies, health system, academic journals wanted to figure out ways to ensure that there was the life-saving information around different changes were being published and synthesized. And this is where professional societies moved in. And then finally, the adapting care, we saw an emergence and surgence of telehealth. We saw care models and care practices that had been used in the past, like proning, being used effectively to treat COVID payments. So we kept adapting as the system moved on. And I think that what this tells us moving forward, or those next steps in the next slide, is really we have to be focusing in on developing the priority opportunities, such as policies and programs to address health disparities. The pandemic taught all of us that there is that continual need to be working together and co-creating fair, equitable, and transparent plans for access, testing, treatment, and services. And this will require increased engagement from clinicians, professional societies, from the federal government to communities. So we really know that this is ongoing and that it is currently under process. We also know that the opportunities and the priority is investing in clinicians. We need to rebuild trust with clinicians. They had this acute stressor that is so important to strengthen the protections for them and training. And then finally, as we think about the other opportunity, is advancing innovations and allowing the infrastructure to change and adapt from the challenges we learned.
Thank you very much, Suzanne. Now let's turn to Bruce.
Great, thank you, Michael. I want to also thank my colleagues who served on the COVID-19 Care Systems Impact Assessment Group. Certainly, the last 18 months have been one of great change, also, frankly, of great trauma and a great heroism at our health systems. And I guess my most fervent hope is that we learn from these past 18 months, learn the good and the bad and perhaps the ugly, and build a better health system with better incentives going forward. First, let's talk about the challenges that we observed. And certainly they were myriad. And I can only touch on a few here in the few minutes that I have. The financial challenges of fee-for-service medicine, the fiscal frailty of such a system, was very much on display during the pandemic, where we saw health systems who were dependent on, essentially piece-based healthcare reimbursement face possible financial damage or even ruin, given the shortcomings of fee-for-service medicine as a model for financing care in an event like a pandemic. And few things could better point up the need for better or more integrated payment systems centered around persons rather than around units of service that are provided. There's the challenges in supply chain were also obviously on display, and many of you on this webinar know more about this than I do. There were great efforts made to correct this, but I think of the supply chain failures as really sort of a triple failure. It was a market failure in which the incentives for individual actors, in this case, health systems and other entities, didn't add up to a good outcome for the nation or for our health system overall. It was a failure of preparedness, failure in which we as a nation have not made the investments to stockpile those things we need in the event or for a foreseeable event such as this one. And I guess at the end of the day, it was also a failure of imagination for all of us to understand what this could look like, or for many of us to understand that. The third challenge, and Suzanne spoke about this, and others will, I'm sure, also, was I would say, and say this mildly, the deep-seated inequities and disparities in health and healthcare in this country. We knew about them beforehand, but boy, were they on display during this pandemic. We saw disparities and inequities in spread of the disease, in testing, in therapeutics and treatment, in vaccination, even in finance, as to which systems received how much money and where they were located. Perhaps it wasn't a surprise to many of us, but I think we also were just struck, and I know I was struck, by how rapidly the disparities were on display and how deep they were, and often as a legacy of structural racism. But with that said, there were bright spots as well. And let's turn to that slide. Those bright spots, just to cover a few. One was rapid innovation. So many health systems that I've talked to and who I've seen experienced a burning platform, not always a pleasant experience, and realized they had to do things differently. And I don't mean just do things differently to meet the pandemic clinically, but to essentially restructure their health system on the fly, eliminate waste, make decisions they perhaps have put off for years, perhaps around consolidation, perhaps around just doing things differently. Change is never easy, but this pandemic forced that. And if, one of those bright spots is that I think many leaders and care systems today have much greater confidence about their ability to change and ability to change rapidly. And that's something I hope that we capitalize on. The second bright spot was embracing public health. And this was not necessarily only a good thing. This was to fill a gap where so much local health capacity or local public health capacity has deteriorated in recent years in our country, that many of our health systems had to step in and essentially serve those public health functions, provide them themselves, in addition to working with local public health agencies. And that was clearly a bright spot in all of this. And a third one I'll point to is system and community-wide collaboration. In many markets, and I could point to Central Florida, I could point to the Atlanta Metro, health systems who had seen themselves as fierce competitors, never as collaborators, came together, and it happened not just in those markets, but many others, to plan proactively as to how to meet this moment, how to do that, metro-wide triage that was essential to meeting the needs of the pandemic, and how to, rationalize capacity and rationalize response. That is something we see perhaps all too infrequently in American healthcare, and it was clearly a bright spot of the response to the pandemic. Finally, what were the opportunities that we see going forward? And I would put them into 4 buckets. And note also that when you talk about cross-sector collaboration, these opportunities around value and population health really point to health systems working with payers, working with public health, and working with digital health. So all areas that the National Academy is covering in these assessments. The first one is obviously going to be social determinants of health and combating structural racism. Unless we can take this opportunity to work in those areas, whether that's through payment incentive, whether that's through broader social policy in this country, whether that's through professional education and so many other levers, if we don't take that opportunity, we'll be back just where we started before this pandemic. And the next time we're in a situation like this, we'll see the same outcome, as disparate and frankly, as embarrassing as these outcomes were from the pandemic. A second opportunity is going to be solidifying and driving care delivery innovation. And things like telehealth are a clear example of that. We have learned so much about our ability to change, or health system's ability to change, and to adopt new technology. And telehealth was perhaps the most obvious and most publicized example. And technologies like that, innovations like that, could have huge, very positive implications for the affordability of care, for the accessibility of it, and for the experience of patients in the healthcare system. It would actually force us to rethink even what the hospital of the future looks like, and rethink how we allocate capital in our healthcare systems. That is a priority opportunity. And our hope now has to be that we don't lose this opportunity, and we don't allow things to go back to what they were before, and instead we capitalize on it. Just like Jeffrey Brenner's cat is capitalizing on the opportunity right now as I speak. A third opportunity is fostering those public health linkages. Those are linkages around data. There are linkages around service. But there are also linkages about how do we work together to affect the social risk factors that were so much on display in the pandemic, as they are in so many other areas of healthcare. And I hope that those bridges that were built during the pandemic between local and state public health and their care systems are not forgotten. And finally, in some ways, we return to the first point I made, the opportunities around risk-based, population-based payment models. So much more to be done. There's a lot of conversation about that today. It was good to hear Jonathan Blum's comments about where CMS is going. But clearly what we've been through for the last 18 months was perhaps the best advertisement for why the status quo isn't working in terms of payment systems, in terms of how our systems were supported during the pandemic, in terms of how incentives were in many ways in all the wrong directions in terms of preparedness. And hopefully, as a learning health system, we will learn from this going forward. Back to you, Michael.
Thank you very much, Bruce. And we'll come back to several of those points later on. As we move to Rahul, I just want to point out that Jeffrey's cat was trying to get closer to hear what you were saying. Rahul?
Thank you. Well, Jeffrey, we'll see what I can do for your cat. So thank you for having me here today. First, I just want to thank Dr. Mark McClellan, who was my co-lead and co-author, and the entire team, and also the National Academy of Medicine team that helped us tremendously through this process. If you could go to the next slide, this is the impact assessment for the healthcare payer space. Just two contextual points for healthcare payers. As Dr. Brenner noted, this is an incredibly fractured space. So healthcare payments flow from multiple different entities in the US healthcare system, both governmental and commercial. And even if you were to look at a commercial healthcare payer, the ultimate source of those funds often flow from multiple different entities. So if you look at a United Healthcare or a single state Blue Cross healthcare plan, they serve large group, self-insured, ACA, individual market, MA, Medicaid. Each of those segments has different rules, different regulatory structure, and makes it very difficult to act quickly. The second is that healthcare payer space has incredibly low public perception. So nobody thinks of their health insurance company as a hero. In rankings of US industries, healthcare insurance companies rank near the bottom. With the possible exception of CMS, people do not think of their insurance company as necessarily heroic. That said, I think that we saw in the pandemic flashes of what could be and rapid action that signals some pathways for the future. So I'll just comment on three of the observed challenges that we identified. One, I think, was common across many of the sector impact assessments, which is the structural inadequacy of fee-for-service. We saw this from a different angle, though. So, whereas many healthcare systems saw the bottom fall out during the months of March and April of 2020 from a revenue perspective, to a healthcare payer where the product is really the network that you field and the availability of healthcare, what had seemed like an inevitability that healthcare costs go up every year suddenly became quite the opposite. And I never personally thought I would see in my own lifetime healthcare costs dropped so precipitously in a period of time. And what that meant is that it threatened the integrity of healthcare networks and the basic promise of access to care. The second was distortion of cost benchmarks in value-based payment models. So a minority of healthcare payers participate in value-based payment models, ACO programs, capitated arrangements. These programs are built upon benchmarks, which are actuarial projections of the future. What will spending look like projected in the future? And the impact of a pandemic varies dramatically depending on how that benchmark is constructed. So if the benchmark was prospectively set, a provider with a dramatic decline in revenue might see a financial windfall. In the following year, in 2021, as healthcare demand comes back based on a suppressed baseline, they might see a very ugly situation, the opposite of that. If the benchmark is set concurrently or retrospectively, they might be just fine. So the pandemic was an unforeseen event that just threw a wrench in extremely complex benchmark construction in value-based payment models. And the third was both access challenges that I've commented on, but also actuarial uncertainty. So healthcare payers set prices in general 6 months to a year in advance of a year, a year in which they field a product. And for a period of time, in March of 2020, the fear among payers, if you had been in the room listening to an executive team talk at almost any payer in the country, the fear was, my goodness, do we have enough funding in our reserves to cover the worst case scenario here, the projected expenditures that will result from pandemic? Then in phase 2 of this, in April to May, as the floor dropped out from healthcare spending because people stopped going to hospitals, stopped going to their doctor's offices, quite the opposite. Payers appeared to be flush with unexpected windfall. And then towards the end of 2020 and into 2021, as demand utilization came back for healthcare services, we saw things leveling out. And it presented an enormous challenge for pricing in 2021, which was a conversation that occurred during the summer of 2020. How do you price for the year 2021 when you don't know exactly what it's going to look like, both from a COVID perspective and then also from the perspective of underlying utilization? Is that going to come back or is it going to remain suppressed? Go to the next slide. The next slide, please. Just a few comments on bright spots and how payers reacted to these challenges. So we saw in very short order, both from CMS mandate and congressional mandate, but also payers acting on their own, the implementation of tremendous flexibilities that would have been unthinkable to be implemented this rapidly in any other world. So payment parity for telehealth services, waiver of prior authorization for hospital use, waiver of prior authorization for essentially any respiratory diagnosis, for COVID testing, and then eventually for treatments related to COVID. We saw on the provider side an increased receptivity to new payment models. So consider what I just said to you 2 minutes ago about the floor falling out from revenue and healthcare cost growth. Well, if you're a primary care provider or a hospital, suddenly the concept of primary care capitation or global budgeting for hospital use doesn't sound so bad. And it doesn't sound as bad as it may have 6 months prior. And so these models are complex and they take a long time to develop and implement, but definitely saw an increased receptivity to these concepts. And many payers, give Blue Cross North Carolina as one example, used it as an opportunity to push the envelope, offering new payment models to providers such as primary care capitation. And then the last point is cross-sector collaboration. Saw payers stepping into roles that they may not have otherwise played. So we'll give you a couple of examples. Blue Shield of California played an important role in standing up and operationalizing the testing apparatus for the state of California, donating manpower, executive time, leadership support. We saw Humana delivering meals to its members and really trying to address the social determinants of health for its members. United Health Group, my current employer, played a role with a number of pharmaceutical companies in research collaboratives to help develop both therapeutics and vaccines for COVID-19. Go to the last slide, and we'll just give 30 more seconds. I think if I had to summarize, this was a tremendous opportunity for payers in the US. And both on the governmental side, the commercial side, we saw flashes of what is possible. So the rapid de-escalation of administrative requirements, new flexibilities on telehealth, rapid advancements in alternative payment models, and new ways of payers and providers working together. I think the two things for the future are of these flashes of brilliance, these flashes of what is possible. What can we keep? How can we maintain some of this this momentum? And the third, the last is just how can we act more rapidly in the future? So as I said at the very beginning, this is a highly fractured space. It's very difficult for payers to act concertedly. And even for a single payer that has different funding sources, very difficult to keep that coalition together to act in an emergency. And so what mechanisms for more rapid action can we design for the future? Thank you for having me here today. I'm happy to take any questions. I'll turn it back over to you, Dr. Mcginnis.
I think we might be experiencing some technical difficulties. And while we are waiting for Dr. Mcginnis to jump back on the line, we do have a few reactors who would like to provide some comments. I'm going to first turn to Nwandu Olayiwola for some comments.
Good afternoon. My name is Dr. Wando Olayiwola, and thank you so much for giving me the opportunity to react. And thank you all for your tremendous work. And I really appreciate all of the perspectives that you shared. I come to you from the payer space as well, and I am currently the Chief Health Equity Officer at Humana. And what struck me as you were all speaking was this theme of hope and optimism. I really appreciated you all sharing, Dr. Miyamoto, the disruptions that were required in this moment in education and redeploying staff and developing new skills. Dr. Siegel, in the way we deliver care and how we linked with public health entities and we forged those stronger relationships. Dr. Rajkumar, how we thought about incentives and cross-sector collaboration. All of those things were great sources of opportunity for us during this pandemic, and I really appreciate both the bright spots and also the opportunities that you shared. As you were talking, I was thinking about a few things. We've absolutely made tremendous gains in talking to each other and leveraging data and really digging deep into the influence of racism, social determinants of health, structural determinants of health, and the impact on our communities. And I guess the question that I think you're leaving us all with is, how are we going to sustain some of the great gains that we've made in the future, and what is going to need to look different? And so I heard a few things from you. One, really accelerating that transition to value and figuring out how do we do that, and how do we do that in a very meaningful and intentional way. We can't afford to abandon or move away from the investments that we've made in the public health infrastructure that has really bolstered our ability to be responsive and reactive to this pandemic. So how do we continue to make sure that we align and invest and support the public health infrastructure that are needed, that is so important for our day-to-day lives? But also, think about how are we going to care for people differently? Are we going to, the great advancements we've made in leveraging technology, we're going to solidify that work? Are we going to kind of revert back to the mean? What are we going to pay for? What are we going to incentivize and value and ask people to really be focused on? I think it's really important as we think about that. We have at Humana, we were able to do millions and millions of screens of our members to better understand the impact of some of their social needs on their health and what they were experiencing during the pandemic. And we've got to do something with that and start to really think about how do the incentives change so that we can be responsive to the things that really matter to people when you ask them. How do we also build on some of these pandemic era investments in structures and data collection? We really can't afford to go back to what we were doing before. And so how do we make sure that we sustain some of that work? And then I guess finally, the last question is, if we are going to really embrace a spirit of innovation and digital adaptation and flexibility and being agile in that space, how are we going to make sure that we don't worsen some of the disparities that we know existed before? How do we make sure we don't expand that digital divide? And so these are all the things that I think would be important. I thank you for all of your really great work and the perspectives that you offer, and how you are tackling some challenges from very different spaces and angles. And I hope that as you've shared some hope with us, that we have the opportunity to continue to innovate and disrupt and think about how we train the next generation of folks that are going to be out in the trenches, responding to pandemics like this in the future, or just taking the lessons that we've learned from this one and making sure that we have a much more equitable system. So thank you all so much, and thank you for allowing me to have the opportunity to react.
Let me, it's Jim, let me just thank you. Return to a second reactor, Christopher Elfner.
Hi there. I agree. Thank you very much for having me as the reactor. This was a very interesting conversation. Actually, two very interesting conversations. As I reflect on COVID, I don't think it really changed our path to value, but it did accelerate the pace in many areas, like digital, like looking at social determinants of health, and really building essential partnerships. And then it raised some areas that weren't on the radar, as we talked about, with equity. So we're doing virtual visits, right? We're optimizing our care paths. A lot of things happened out of necessity because we had to do them a certain way. It was either don't deliver healthcare or deliver it in a new way. And we need to be very careful that these terrific things that happen don't go backwards, right? And continue to sustain them and move at that same pace without hopefully another pandemic or the existing pandemic, but coexisting with COVID. That major healthcare pause that we all did caused a lot of damage that wasn't COVID damage, but non-healthcare damage. And we really need to understand how we can coexist and how do we make sure those things work. As I look at what we've learned and kind of the themes, the general themes as we move on to value, kind of what I've heard, what I pulled out of many of what you all just talked about is we really need to align and engage individuals and families in their own health. And digital is a critical aspect of that, right? But we don't want to make digital simply a replacement for what we've already been doing. It's a new tool that lets us deliver care when and where and how an individual wants it and stay connected with them in between visits, right? We don't want to say we need you to do a virtual visit and try to replace what we're doing. We want to do more. And that means aligning and engaging the care teams, right? They need to move to a population health mindset and likely a population health incentive model that aligns everybody on making the communities they serve thrive, right? So there are essential partners, not just in healthcare, but outside of healthcare. You know, certainly public health and other healthcare organizations, but there are lots of social programs and the social determinants of health, and we really need to think about what the well-being of those we serve and what drives that. You know, if somebody's experienced a crisis, they're probably not going to care about their A1C score or their cancer screenings. Partnerships, I do think if we all were to align on taking responsibility for the communities we jointly serve and making them thrive, we can now talk to employers, we can talk to schools, we can talk to governments, we can talk to all these different partners and really surround those individuals and those populations with the care we deliver. And we want to affect that total cost of care. Healthcare is taking too much of the pie. So how do we pull that information back and make sure that the shared savings that we're producing are going to the buyers and not just the health systems and the insurers, making sure that it's felt by the taxpayers, by the employers, and by the patients and the families that are being served. And to really reduce cost of care, we need to reduce our cost to deliver care. We need to be more efficient. We need to make sure the care we're delivering is achieving the outcomes we want and get rid of any low cost care models that we have. And then, you know, COVID really helped us. Those who already had that deep knowledge of the population were in a much better position to react and interact. And then the last piece I would say is that interoperability of the healthcare systems is really, really critical. Claims data from payers is very useful for understanding and knowing where to start, but often that opportunity for action has come and gone before that information is available to act. We need to be able to interact in a much more real-time way and know when somebody walks through a door so that we can implement a care pathway for those individuals. So the last piece, and we talked about it, is I think a lot of us learned about harnessing the ingenuity of our community to locally source PPE. Just a very quick example. I didn't even introduce myself. I'm Chris Elper from Bellin Health in Northeastern Wisconsin in the UP. And our best supplier during COVID was the Wisconsin Face Mask Warriors, who delivered over 10,000 masks to our system. And every single day, we got a delivery of those masks. They were local people sewing masks and delivering them. We need to make sure that we are supporting our community and getting whatever PPE we can locally so we don't get into the issues that we had where we didn't have what we needed to provide the care we want. My last piece of advice is I think COVID taught us to move fast, and I think we need to keep moving fast and not fall back to all the reasons why we can't do things.
Thank you, Christopher. And our third reactor is Karen Smith, who's a private practitioner in North Carolina.
Thank
Karen,
you.
are you there? Yes.
Yes, I am. Thank you so much for allowing me to respond. I think so far what I have heard is absolutely spectacular. Suzanne and Bruce and Raul, you laid it out. You told us and you have spelled out what we observed and the responses to a lot of what has happened. But I want to summarize it a little bit. How were we able to make a difference in terms of the role of the physician, the role of the provider in the community? Well, we had a network that was already forged. We had partnerships that we had already established. But COVID forced us to now connect. And then we communicated, we collaborated, and we were challenged. And then we also challenged the system to come up and create a healthcare system that would allow people to really receive the care that we felt was necessary and it was life-saving. So long we have dawdled in the downstream in terms of the impact of policies and regulations, which many of which may be ineffective and some even toxic. And COVID really opened our eyes to what was happening downstream. When we look at inequities in care, when we look at the primary care workforce not readily identified at the beginning of the pandemic, and how can we move beyond that? And then the fact that our hospital systems, our insurance players, everybody came together, our payers came together, our accountable care organizations came together to support the community, to support those providers of care in the community. We were connecting, and then once we connected, we sat at the table. We sat at the table and we started to collaborate in regard to what do we need to do? And how can we make a difference for the now, but what about for the future? And that came from sharing those stories, listening to the fears of providers trying to give care, but they had no PPE, and the financial viability. Are we going to be in business in 3 months or 6 months? And we gave those stories. And then how do we readily adopt the telehealth? We gave those stories and we showed and made it clear in terms of how does it actually work in the community. And then we looked at all of the other impact from COVID. But I think the spark was what we all witnessed, looking at the inequities and the death of George Floyd and looking at the death of others whose lives were taken that had nothing to do with COVID, but highlighted what we know was racism and behaviors that was having an impact. So we come to the table. How can we now launch forward? I've heard over and over from our patients saying, I just want to get back to normal. I want to get back to before COVID. Yet I've heard 2 others on this conversation say, no, we don't want to go back. We want to launch forward. And how do we do that? How do we avoid going into our silos and looking at our own infrastructure and not paying attention to infrastructures that really need to be dismantled? Policies that really need to be taken apart and create something new, anti-racist policies, anti-racist procedures, so that we can really launch forward. It is so appreciated to see the NASEM report, to really identify the role of the primary care workforce and that impact that it has on the community when we strengthen our primary care workforce, when we look at digitalized medicine, when we actually provide the finances that's necessary for these doctors and providers of care to actually function in their communities, as well as making sure we're paying attention to well-being. And by the way, administrative burden reduction, we saw that. And I appreciate Raul's final slide, and that's where I'm going to close out, because that slide really highlighted all of those aspects that many of us felt made a difference. We don't want to go back. We want to launch forward. And if there's a way for us to continue to do that, that's what we really should focus on. I thank you for allowing me to respond to such an esteemed group of individuals and wonderful conversation, moving us in a direction where we all agree we need to move forward.
That was great. That was just great, Karen. Thank you. And let me just also thank Nwando and Christopher as well in their role as reactors, and Suzanne, Bruce, and Rahul for their work in leading these sector impact assessments. 3 of them that we've heard. The others are on the National Academy website, and they're all rich like this. And I think we all sense that different sectors were seeing the same thing through a slightly different lens, allowing for the power of collaboration when it occurs. I think at this time we'll move on to the next section, and let me just ask if Michael is back.
Well, can you hear me?
We can.
Okay, good. Well, thank you very much, Jim. I'm sorry. One of these hazards of working remotely, a lightning bolt just struck right next to the house and knocked everything out. But in any event, I appreciate your pitching in, and thank you with apologies to each of our previous speakers. And so we're a little behind. And if you can still hear me okay, can you?
We can hear you just fine, Michael.
Okay, good. Then I'll move us to the next session, which is going to be focusing on the roadmap themes. And we have 3 panelists, Amol Navate, Cindy, who is from the University of Pennsylvania, Cindy Mann from Manat Health, and Mai Pham from the Institute for Exceptional Care. I want to just underscore that recognizing the necessity and opportunity for a systemic transformation along the axes of value and incentives following the pandemic, and informed by the sector impact assessments that we've referred to and heard a little bit about, the consortium is currently engaged in a number of efforts that are aimed at adjusting health system incentives. And we're going to hear from the leaders of 2 of these efforts, financing that rewards better health and well-being, and catalyzing innovative health system transformation through the work of Cmmi. And I'm going to dispense with the other sort of more formal remarks, because I know we are a little bit behind, and go directly to Amol Navate, who is Assistant Professor of Health Policy and Medicine, Commissioner of the Medicare Payment Advisory Commission, and leader of the Catalyzing Innovative Health System Transformation discussion series in support of the Cmmi. And followed by him will be Cindy Mann and Mai Pham, who I'll introduce at that point. Amol?
Great, thank you, Michael. So this work group had a fantastic, very engaging discussion around how to catalyze reform through Cmmi. And I think much of the call to action is something that we discussed as part of prior elements of this meeting itself. So I'm actually also, in the spirit of time efficiency here, going to skip much of the context. I think we all know that we're on an unsustainable cost growth. We have persistent and prevailing disparities, even in very common conditions such as hypertension, diabetes, congestive heart failure. And COVID-19 only accentuated the fragmentation in our health system, as well as the disparities that we've seen in inequities. So a broad focus here was really to sort of consolidate lessons from the past decade. Cmmi obviously is now entering its 2nd decade. It has done a number of different tests. In fact, it was quite impressive to see the exhaustive number of demonstration projects and initiatives that Cmmi was able to successfully implement over only 10 years, really expansive. And I think as the work group contemplated the next decade and beyond, there was this general sense of moving from a testing frame to what we might call a transform frame. So less about testing for the purpose of testing and more consolidating those learnings and trying to be much more targeted in accelerating those elements that do seem promising, while testing in a targeted fashion to complement a more coordinated approach. And that coalesced really into 4 key domains of priorities going forward. Number 1, beneficiary as North Star. I will touch on each of these a little bit more in detail shortly. So beneficiary as North Star, number 1. Number 2, equity in every policy, really advancing equity through the value-based payment, alternative payment model frameworks. Number 3, community and social drivers of health fully engaged as part of payment reform efforts. And number 4, ensuring that payments are integrated and aligned. So this is the vision that we are trying to achieve over time. All of the payment programs eventually should have these 4 features. So let's talk about each of these in just a little bit more detail. So number 1, beneficiary as North Star. What does that mean? So what that means is, to date, there has been an emphasis on value. Now, the construct of value has been something akin to quality for a given amount of spending or a given amount of healthcare costs. But the question is that value to Medicare? Is that value to the providers? Or is that truly value to the beneficiary? And where does the beneficiary's assessment of value come into the so-called value equation? And we can imagine in many of the different types of practice changes that might be required to get to a more efficient system, those very same practice changes may not be perceived as enhancing value, the patient experience, for example, ease of accessing care, or what have you, from a beneficiary's perspective. So the goal here is really to remember and place the beneficiary back as the focus of all of payment reform efforts, of all the value-based payment, the value-based care delivery efforts, broadly speaking. And the goals here then are kind of articulated in a few next steps. So one concrete next step, try to articulate specifically to beneficiaries and their families what the benefits of each of these models and this program of change is intended to be. I think as we clarify the language around articulating that benefit, we will also clarify the type of additional experimentation, the type of additional metrics and measurement that we might need to get there. Second piece of this is the next step, is query the beneficiaries at least annually. Find a way to get beneficiary input into these definitions of value, into the way that these programs are being developed and being implemented. And third, announce this in public conversations. So make this a centerpiece of the language that the center uses itself around payment reform efforts. Shifting now to the second big bucket, big dimension, equity in every policy. There's a core step here that is common ground for many of the other efforts, which is we need enhanced data collection, particularly around individual social factors. To date, we tend to use proxies, either from the geographic level or other characteristics that we observe for individuals. Frankly, that's not going to cut it. So we need an enhanced effort over time. Not to say that progress and equity needs to be forestalled until we collect that data. So we do need to use the measures and the data that we are collecting as effectively as we can. For example, stratifying by different populations where we know that disparities exist. In developing measures, Cmmi has an opportunity to collaborate with other organizations, even within CMS. For example, the Clinical Standards and Quality, CCSQ, agency within CMS or division within CMS is specifically about metrics, as well as the Center for Medicaid and CHIP Services. Other organizations like NAM, for example, also can be partners in this effort. Cmmi models in general should require assessment of outcomes related to equity as part of the standard practice, not as an exception. And the groups that we're talking about are the groups that would be familiar to you. People of color, those with low income, those with disabilities and chronic conditions, children with special healthcare needs, amongst many other groups. There's also a call here to directly link payments to closing gaps and disparities, using payment as a lever as part of value-based payment models to directly affect inequity, improving equity. And lastly, to conduct equity audits. So Medicare and Cmmi as a standard practice, as it evaluates its programs, should be conducting equity audits, not to only monitor the impact in a post hoc fashion, but also to inform the proactive design of models that have a core intention to address inequities as part of their core goals. The next steps here are, as I just mentioned, very concrete. One, require data collection on these individual factors as part of all future payment programs, and introduce this idea of an equity audit on a regular basis for all models. Third bucket, community and social drivers of health fully engaged in the payment reform process. Much of this can build upon existing efforts, such as the Accountable Health Communities effort that has been promising, has yielded great results to date. The core idea here is to engage non-medical home and community-based care, so home care and community-based care, wherever possible in all payment models, and to expand support in populations, in community health, in medical care, public health consortia, for example, wherever possible. Try to create as much coordination, in other words, between the formal medical care sector, the informal medical care sector, as well as, importantly, the social services sector. And I know that Cindy coming up here will talk more about that. This could include testing new programs that include universal screening for social drivers of health, that test navigation programs around community services, perhaps infrastructure investments that are common to human services and health services or medical services. The next steps here are to establish capacity to work with states, because states are oftentimes at the forefront here as part of their Medicaid programs and as part of their public health work. And there's a need here to express, to articulate a robust commitment to the idea of social service support models as part of the broader health delivery human services paradigm. Fourth bucket, getting to a system where payments are integrated and aligned. This is a space where the decade of experience has actually yielded a number of different efforts. Yet at the same time, while we've had promising results, we've also had areas of opportunity that have popped up. There's been a clear lack of alignment in models within and across payers from a national perspective. Providers in general have been pulled in multiple directions, not having a common set of metrics, a common set of methodologies, a common set of ways to actually participate in multiple types of models. And this has at times distracted from the core delivery changes needed to assess, to improve healthcare. So now is the time for Cmmi to step up and drive that forward, to try to make a commitment to reducing the number of models, to consolidating, as we talked about earlier, to a set of models that are more evidence-based, based on the evidence that we do have, with targeted experimentation to complement, trying to get to a future state where we have multiple coordinated models that are working together to drive change. A few of these features will be required, ideally, of most, if not all, models. Number one, as we talked about, multi-payer alignment to address this issue of providers being in multiple spaces at the same time, or multiple systems at the same time. Another is use mandatory requirements, mandatory participation wherever possible, recognizing that it will not be possible everywhere. This has a major benefit in terms of standardization, replicability, as well as the ability to assess the impact and effectiveness of specific programs. And last but not least, develop a roadmap and action agenda from a population health perspective, including advancing health with relation to the Medicaid population. So this will require a hybrid approach, mandatory and multi-payer initiatives, perhaps population-based models, perhaps also episode-based payment models, picking up upon those mandatory models that have already demonstrated some benefits, and also developing pragmatic playbooks or toolkits to assist providers in the transitional state of getting to our future vision. The next steps here, including announcing and articulating a vision. This signaling piece is particularly critical because the return on investment for the types of investments and the magnitude of investments needed to make change is a long one. If we don't articulate, Cmmi cannot articulate a long-term path of change, it's very hard for the provider sector, broadly speaking, to make the investments needed to navigate those over time. That will come alongside an expressed intention for system-wide transformation, using Cmmi and the Medicare platform as a way to change the entire system, not just Medicare itself. And there's a convening role here as well. Convene leaders, chief executives from health plans, large systems, delivery systems, and multi-stakeholders to get a unified approach that can actually work and can be scaled. So let me stop here with the last point that I really want to amplify this point, that the signaling piece, trying to get out an announcement that reflects the administration and Cmmi's commitment to the future of where we're headed, is an incredibly important point, providing a timeline with some specific targets, just as HHS did in 2016 with Secretary Sylvia Burwell, which helped propel some of the momentum that we saw over the past decade. Let me stop here. Thank you very much for listening.
Thank you, Amal. And on the signaling piece, as well as on the movement of CMMI from testing to transformation, we've already heard dimensions of that from Jonathan Bloom, so they're listening to your suggestions. And now let's move to Cindy Mann for her additional perspectives on the role of the activity that we've done with and for CMMI.
Sure. Sorry, shutting off my phone. Great to be with all of you and to hear the remarks. I had the pleasure of also serving on the same expert panel as did Amal, and we looked at, as he described, particularly ways that CMMI can promote better value, better integration of our healthcare system. So I do a lot of my work in the Medicaid space, and Medicaid has been, I think by all accounts, often the stepchild of some of the transformation activities. So I think there's a lot of energy to turn that around at CMMI and to really focus on some of the unique features about the Medicaid program. But I'm really going to use Medicaid as an example, not just to do a plug for including Medicaid in transformation, but really to shine a light on some of the problems that we have and some of the issues that the expert panel really identified as important to address. So when we talk about value, I know I was in the administration when Sylvia Burwell was secretary, and there was a sense from the Medicare people that, oh, Medicaid relies on managed care. And so we've already gotten a lot to value in Medicaid because we have managed care organizations dominate the delivery of care. They take on risk, and the theory is that risk will push the Medicaid managed care organizations to achieve greater value for the dollars spent. And yet I would guess that most of us would say that Medicaid and Medicaid managed care has not fully moved to value in a really fulsome way, and there's a long way to go. And it's largely because if you look under the hood of Medicaid managed care, the MCOs generally pay the providers on a fee-for-service basis. So what really goes on is providers are being paid for volume, not for value, and the MCOs are managing care to keep their overall costs in line with the rates paid to the program. Many states and plans have incentives or withholds to promote priorities, leading to greater value. But too often they're really not sufficient in size to move the needle. And going to the alignment point that Amal raised, what we have is a situation where any provider who's serving patients enrolled in different Medicaid managed care plans, but also covered by different payers, whether it's Medicare or commercial insurance. Those providers need to do different things to be able to earn those incentives for those particular payers. And that is really giving up an opportunity to really move the needle in terms of our delivery of care. It's also the case that integration in the Medicaid program is not always as strong as it needs to be. Some key services, while managed care is the dominant form of delivery system, some key services are carved out of managed care. Often, most notably and probably the most damaging in many ways in terms of the benefits of integrated care is mental health and substance use disorder, is just had a history of growing up in a different way, often in communities, county-based locales, and often the system of delivering behavioral health services is very different than physical health services. We also see long-term services and supports still pretty much a stepchild of the healthcare delivery system, when we know that for people with disabilities, we know for frail and vulnerable elders that long-term services and supports really is very much part of their integrated care plan. And then, of course, the issue of social drivers of health, which have not traditionally been part of the regular delivery of healthcare services or payment of healthcare services. And so it too is to the extent that it exists in some delivery systems, it is also pretty much off to the side. So notwithstanding that state of play, there's a great deal of energy across states to move much more aggressively to value and better integration of care, sometimes referred to as more person-centered, whole person approach to care. North Carolina calls it paying for health, not even health care, just paying for health, which is a good phrase to think about in terms of what it implies. So that typically requires bringing these interventions together along with social interventions to address social drivers of health into the system of delivering healthcare. Many states and health plans and health systems are trying to do that, but there's a lot of confusion and a lot of debate out there. What social drivers should be addressed in the context of delivering healthcare? How can they be addressed without medicalizing social services, or on the other hand, without healthcare providers having to take over the provision of social services, which is not their expertise? And of course, some of the most vexing questions is who's going to pay for addressing these social drivers of health? The bottom line is that pre-pandemic, we had a lot of state Medicaid programs across the country in various stages of promoting value, of moving towards better integration and addressing social determinants of health. But the initiatives were often too small to make a big difference. Pilots, not necessarily pulled into the fabric of what I think of as the regular Medicaid delivery system of care and payment for care. And also, while most everyone was well aware of the disparities in our healthcare system, many program administrators and leaders considered that something perhaps beyond their ability to change. COVID, of course, changed everything, and we've been talking about that for the last for this period of time. But let me give you a couple of COVID examples. They're hardly unique, but it just shows that we have a long way to go, but the path is not necessarily hard to discern or out of reach. So in the earliest stages of the pandemic, state policymakers, program administrators, and hospital administrators understandably worried about hospital surges. In many cases, early on in the pandemic, patients were discharged to nursing homes to preserve hospital capacity before there was any assurance that the nursing homes, also paid for mostly by the Medicaid program, were safe to receive patients. We're able to cohort those with COVID-19 and treat people who had more complex medical problems than the nursing homes were accustomed to treating. For this and for many other reasons, nursing home deaths, of course, skyrocketed. But one state who had a very worrisome early first couple of months around this issue, after seeing a large surge in nursing home deaths, took a relatively simple step. And really what they did is pair nursing homes with hospitals. In other words, in a small but significant way, they were able to improve coordination, have a discussion back and forth. Are we safe to discharge patients? If not, if so, what kinds of patients and under what circumstances? And we also had better management, healthcare management of patients by having hospital clinicians really lend their expertise to the nursing home staff. Looking more at the population health side of the equation, as hunger and homelessness grew, many policymakers started to address this, and we really saw a lot of use of CARES Act money and other one-time dollars to be able to bridge that gap between the delivery of healthcare services and social care. We saw when hospitalizations and deaths also became apparent, we saw many states acting in this area. We had some health systems that really focused a lot on the equity implications of what they were seeing from the pandemic. They looked at who they were hiring and how they made clinical decisions. They considered how they were paying for so-called safety net providers or home care workers who themselves were disproportionately people of color. And they asked simple questions like, are they making it possible for a person to comply with medical advice if she can't leave her job to come to a medical appointment during normal hours? These are equity issues that are embedded in every decision that's made in our healthcare system. And people rose to the occasion by and large, including the federal government, which put a lot of barriers to better integration and quicker action, remove those barriers through flexibilities that were permitted to states and state Medicaid programs. So the question, of course, is how can these efforts be corralled, be strengthened, and be put on a sustainable path, and do it in a way where health equity is always a part of the equation. So as Amal described, and I'm not going to go through it again, rather than the panel suggested that rather than simply building new models, that Cmmi really facilitate a system-wide alignment in aims and in strategies, making available levers for changes that are needed within CMS, all the programs governed by CMS, and across HHS and throughout the administration. So some of what's needed, and I'm going to go briefly on these because Amal covered many of them, of course, is better data, core data on race, ethnicity, social and economic status, disability status, social drivers of health. And I would argue that collaboration is really important. Lots of people have really good ideas on this, but we need the federal government to lead and to really make headway on this. We don't need 50 states and the Medicare program and the marketplace and the commercial market and health systems and different health plans going it alone. This is an area where we really need to pull together and have some leadership. The group also really emphasized the engagement of non-medical home and community-based care when applicable, where applicable in all payment models. And that's actually a very significant recommendation and really changes in very transformative ways the nature of the delivery of healthcare and the payment of healthcare. Some states have successfully leveraged the Medicaid authorities to promote this kind of engagement, but the questions arise that only the federal government can facilitate and can address. For example, which of the federal sources of fundings can be accessed by health systems trying to improve and address social drivers of health? How can key data sources be leveraged in a way that is respectful of people's privacy? And what quality measures can be employed across markets to assure the efficacy of investing in social drivers? And how can payers risk adjust to promote greater equity and deeper engagement for people with complex health and social needs? And very importantly, what new models for financing social drivers can be identified and supports? We still live in a situation where the focus on social determinants of health is driven by how much can a Medicaid program or a managed care plan or a health system save within 12 to 18, maybe 24 months. That's an important consideration, but it can't be the only consideration. For example, when you do that, even though there's certainly a return on investment for kids in investing in social drivers of health, that return on investment doesn't show up in 18 months. So we need different kinds of methods of financing these social determinants. We're working on children health and wellness funds to bring in different financing sources based on different interests and benefits across a broader segment of not just the healthcare industry, but also business and government. Only the feds can really promote greater alignment across delivery systems. And so I think we all need to really push the feds to be moving in that direction. And in my view, that doesn't mean making everything like Medicare, but finding a sensible landing spot across markets and payers. So the federal government certainly can't do it alone, but they have an array of willing and equal partners. And our panel really believed that substantially moving the needle on value, on integration, and on whole person care is well within reach, but only by taking bold and transformative action. I can turn it over to Mai.
Thank you very much, Cindy. You've heard from two people who were part of this expert panel with Cmmi, which dealt really very skillfully with the roadmap elements that relate to concepts and principles and innovation examples. And actually, one of their other participants in the expert panel, Mina Seshamani, is now the new head of the Medicare program. So there is a convergence of perspectives there. And now we're going to turn to Mai Pham, who was the co-chair of a series of 3 meetings that were extensively focused on the strategic elements and how we can practically move to the kind of integrated payment perspectives and practices that have been identified and are necessary. Mai, can I turn it over to you again with thanks?
Thanks, Michael. And I'm going to presage for you all that you're going to hear some very familiar themes, although as what you heard from Amal and Cindy, although perhaps in language that makes it sound the opposite, which is not true. So the workshop on financing that rewards better health and well-being was focused on what it means to actually produce good health, and this radical concept that good health is health that allows people to thrive to their fullest potential, which implies one of several guiding principles that derived from the conversation. First, that in order to know what is important to people, you actually have to share power with them at a community level and give voice to individuals and stewards of their health in order to actually articulate what their priorities are. While hemoglobin A1C, for example, might be on the road to being able to attend school full time or take care of your grandchildren, hemoglobin A1C may not be the right metric of those outcomes. A second key principle was this concept of targeted universalism, which is the notion that flips on its head the argument that we should care for vulnerable populations and address health inequities because it is the right thing to do. It is, of course, the right thing to do, but it also will have the predictable benefit of benefiting others outside of that vulnerable group. That is the notion of universalism. So, for example, when you design health education materials in plain language, it turns out the people you help the most are not people who read at plain language level, but people who read at a 12th grade reading level, because you had mistakenly assumed that they wanted something that hard to manage. A third guiding principle has to do with collaboration, and I won't hammer on that because a lot has been said about the importance of breaking down silos in every aspect of system design. Financing, payment, how services are organized, but also how outcomes are measured and priorities derived. We've also heard from Cindy and from Amal about the need to rethink how we calculate returns on investment and strive for longer time horizons in order to actually match the production of the outcomes that we're interested in. But I would go a step further to say it's not enough to say that we should create new methodologies singly at either an agency level or within a health system, but that we really need to revisit in a concrete way with the profession of healthcare actuaries and chief financial officers what the industry standards could be and how they might be refined and modernized to allow for our new understanding of these longer term goals. And then lastly, to both foster collaboration and competition simultaneously, that it is possible to do that within a regulatory structure if one is willing to be flexible, to place the weight of greater incentives in certain directions to promote early adoption of system changes, and even take the radical step of considering that under certain circumstances, politically and operationally, it may make sense to add net new investment into the system and not just try to reallocate resources from low value services to high value services. So with those guiding principles, we then launched into trying to vision what this new world might look like that produces whole person and population health. And we reviewed quite a number of models that by one measure or another seemed to be getting it right. And the question really was, were they getting it right? in spite of or because of financing and payment approaches that they were exposed to. Some of these organizations, such as community health centers and FQHCs like the Achievable Foundation, were supported by cost-based reimbursement. Others, like the Veterans Health Administration, functioned under set budgets and salaries. Yet others, like City Block and Oak Street, really had their models supported by venture capital and, of course, philanthropy and grants. And you'll note that none of the arrangements I just mentioned are actually broadly scalable or sustainable in and of themselves, which is just a reflection of how broken our current financing systems are if the success stories all relied on exceptions. We looked a little bit at the evidence for how well those models performed, and we also learned that payment is a necessary but not sufficient ingredient because there are other cross-cutting traits that tended to predict the success of a model. In particular, the depth and commitment with which they approach community engagement in order to really internalize and operationalize the community's priorities, the extent to which they managed to break down silos in order to get the work done. And so then, we also looked at a brief case study of a model that has tried and failed to deliver whole health and learned, not unsurprisingly, that it was because of fee-for-service financing. And so we learned that it's not just the structure of payments, fee-for-service, capitation, cost-based, what have you, but also the levels of payment. That may be an obvious thing, but it often gets forgotten in the arguments over how to structure payment models. One forgets that the pricing is also really critical to get right. And again, that brings us back to the implication of the need to consider whether and when and how we might need to put more net new money into the system, if only on a temporary basis, in order to get change going, even as we try to reallocate from low value spending. So then we moved to thinking about what the actual approaches would be to incentivizing whole person and community health. And that meant addressing current payment roadblocks and strategies for overcoming them. In terms of the what makes for better payments, we've already mentioned the longer term ROIs, but we also need to mention that it isn't just paying for the direct services themselves, it's also making investments, as earlier speakers have alluded to the connective tissue that fosters integration. That's not just data sharing, that's not just common understanding of grossly simplified outcome metrics and shared accountability, but it also means workforce investments, and it also means structural investments in service sectors that have not gotten that kind of investment before. Cindy talked about home and community-based services, which has never had a high-tech program. They've never had a federal investment in their practice management or electronic record infrastructure. And so they would make a very unequal partner to the clinical side of the house. So that's the what. In terms of the how, absolutely extensive collaboration, but collaboration that includes consumers and unlikely non-traditional actors, not just your usual run-of-the-mill purchasers, public and private, but also investors, also the urban design experts in a given community, also landowners who may have things that they can contribute in kind and or a stake in the outcomes. So truly opening up the opportunity for collaboration to as broad a group of stakeholders as can move in a constructive manner. And what's really important is that we are going to have to make some hard decisions, which implies that at the end of the day, there's going to be a lot of horse trading. How do you make dramatic reallocations from low value spending to high value spending? How do you remove, without offending anyone? You can't, you will offend someone. How do you remove the frictional costs, which are driven by the fragmentation of our system, the multitude of payer rules that a given provider practice has to deal with, adds low value costs to the system. So to the degree that that we can't do these things, that is where the option of putting in, at least at an early phase, net new investment in order to grease the skids might have to be on the table. Having said that, if we're going to consider offering net new investments, there is an opportunity here to steer them toward early adopter communities and communities that are serving particularly vulnerable populations, and as well to offer more favorable arrangements to providers who are early adopters and who are willing to give up something else they have that is of lower value, all in an effort to foster competition. So it is this careful dance between competition and collaboration that we want to get right, so that we can leverage all of those core human instincts among us. And then lastly, the who. Who are we focusing all of this effort on? We can't boil the ocean. And while there is a lot to be said for the power of federal government to put out common approaches, at the end of the day, collaboration is extremely hard work, and it is community level work. And it has to be designed thusly. And so if we can't boil the ocean, how might we go about prioritizing which communities to invest in first? And the workshop participants very strongly came to the consensus that it should be those communities that are serving the most vulnerable. And within the communities, targeting further to the most vulnerable populations, including children, individuals with disabilities, the elderly, and people like people of color who have experienced chronic disparities. So that's the framework that we took into then hammering out what immediate, intermediate, and long-term actions might look like. Cindy has already alluded to the necessity of having the federal government play a core central role here. That said, the federal government can lead on some things like setting standard metrics, creating the data sharing infrastructure, but there are other places where federal government, frankly, it's more important to give permission and to step out of the way and remove barriers based on the priorities identified by states and by communities and the stakeholders within them. And then helping them to, in a targeted fashion, identify the regulations, the current laws that stand in the way, and offering targeted relief so as not to trigger utter chaos. And then carefully watching that experiment, but allowing it the length of time to really be fruitful while tracking any potential unintended consequences. So that's a mouthful to say, and it's a tall order, but it is a cohesive vision. And we think that given the energy in the current administration and CMS across multiple centers, not just the Innovation Center, to really address disparities, to really think about whole health as the end product, rather than just total cost of care savings, understanding that they are both important. We think there is a moment in time here where the ground is soft and a lot of work can get started. Thanks very much.
Thank you very much, Mai. And as you said, the vision that you, along with Amal and Cindy, laid out is a cohesive vision. Indeed, I want to apologize to our listeners as well as to you folks for not being able to take questions, since the insights, the thought, the expertise, and the cogent presentation you all had of a very complex set of issues was beautifully presented and captures very well the fact that we do have the elements of a roadmap in hand. And although it's not entirely adequate replacement for the issue of questions and answers, I will say there will be electronic follow-up on these issues, both on our website, and our organizers will post in the chat or the questions the website loci in which you can get a copy of the expert panel's insights and recommendations for CMMI, as well as both the agenda for the workshop series that Mai co-chaired, but also as a coming attraction, the special publication on the strategic elements that will be forthcoming from the National Academy of Medicine. So again, thanks to each of you, and we'll move straight away now to the journey forward, the discussion on practical action as a logical extension. And Jim, back to you.
Well, thanks, Michael. So we've had a great discussion of some of the sector impact studies and themes from the leadership consortium. And now thinking about aspects that have been put to practice effectively, and what kind of practical learnings can we have going forward from those experiences. So this session focuses on concrete action steps, opportunities, incentives, and levers that the field at large might be able to use to accelerate this health system transformation toward more optimal financing structures, as we've seen, particularly related to the COVID-19 pandemic. And so we'll hear from the three individuals in this panel over the next 40 minutes who can reflect on their own experiences with this practical aspect of approach. David Pat is former president and CEO of St. Luke's Health System in Boise. And Dr. Judy Suranzan-Thal is Chief Medical Officer at Washington State Health Care Authority, and Eric Fennell is Vice President of the National Network Strategy, Innovation, and Value-Based Solutions at Aetna, which you now know as a CVS health company. And I would ask all three to maybe state in your comments how your comments reflect on the prior conversations today and comport or not with your own experience. So David, let me turn it to you first. David, you may be on mute.
I was. You think I would learn this by now? Sorry, Jim. Well, I certainly agree with the earlier comments. I haven't been able to participate in the entire conference so far because of another obligation, but of the things that I heard about, one of those being something of great importance, the healthcare inequities and disparities that we see. Actually, our transformation to value at the health system that I ran significantly helped. We certainly haven't remedied the situation, but we've certainly made progress, and value certainly does help promote that far better than fee for service. But I agree, we've got to move to value-based arrangements. And I think certainly what we've seen is it's really those higher levels of value-based arrangements. There's limited opportunities through upside only. Providers have to take accountability for the costs and outcomes of care if we're going to make a difference. And that's what we did at St. Luke's.
David, I learned from you and didn't unmute. Judy?
Sure. Hello, and thanks for inviting me. This has been a really great conversation. So I'm the Chief Medical Officer for the Washington State Healthcare Authority, and we purchase care for more than 2.5 million Washingtonians. So we cover Medicaid, we cover public employees, we cover teachers and retirees. All of that is about a third of Washingtonians. And we have been focused on value-based purchasing and how we use our dollars more effectively to get health since 2013, when we started with our SIM grant, and have continued on that with a number of waivers. And we've had some success at that, I think. Our most recent survey was in 2019, And 62% of our healthcare spend, again, across all those contracts, Medicaid, state employees, and teachers, are in value-based contracts defined as levels 2C and above in the healthcare payment learning and action network. But that being said, I think we have a lot more places to go, and I think this conversation has resonated some with our thinking on what to do. And so to talk about some actionable concrete steps, which I think was our charge, I think first I want to say we have a need for speed. We've been talking about value, we've been talking about low value care, we've been talking about all of this for decades. I've sort of grown up in talking about it, and I think it's time. COVID has given us a bit of an opportunity to see how things can be different, and that we can change quickly when we need to. And so we need to sort of push on that ability to change quickly to make a real difference here. Second, and this has been brought up also, I think we need to do something to make fee-for-service less attractive. Change is hard, and people have a very predictable, knowable income stream when they bill fee-for-service. And so we need to figure out either how VBP models look different, are more attractive, or maybe even, and this is slightly provocative, we take the step of decreasing fee-for-service reimbursement rates. And maybe that's a glide path over time, because again, it's hard to do, but how do we make fee-for-service look less attractive so we can build up different kinds of VBP models that really get to person and population health that we want? So next, I want to take a moment to talk about models and sort of what to do around models. I am a true believer in multi-payer models, and we heard some of that again this morning, particularly about Medicaid and Medicare working together, which I think has, being from a state, I think there's a lot of opportunity there, but also I think bringing in commercial payers. And one of the things we've done in Washington State over the last couple of years is create a multi-payer table to improve primary care in Washington State. And I think, and we are working on building and implementing a model that aligns both general payment methodologies, not exact, to allow some wiggle room, but a general direction, and aligning quality metrics, because as I think has been talked about, and you all know, our healthcare system is very fragmented, and it's very hard as a provider to change some of these things when it's just one payer doing it. Really having the bulk of payers pointed in the same direction and encouraging clinicians to move in that direction, I think has a lot of promise. And in making those models, I think it is critical to look at equity and social determinants of health. And I would argue that even on our commercial side, there are people with social determinants needs. There are people that are impacted by equity. And so I think this is not just a Medicaid problem, but an everyone problem. And I think that we can work on it together. Also with the models, I think primary care is very low hanging fruit in thinking about how to build social determinants into that, how to build community connections. But I also think there are things like maternity bundles, joint bundles, things that can be built upon to keep moving us in the right direction. Next, I want to talk about equity. I think a very easy thing, we for sure need to make more progress on equity and social determinants of health. I think one thing that even we are bad at is measuring race, language, ethnicity. I think having some standard for that and requiring it in quality measures and health outcomes is a good next step to go. And then building, as we build these models, how do you risk adjust for medical and social complexity? I think we don't know good ways of doing that, although there's a lot of interest and a lot of smart people working on it. And so we definitely need to continue that work. And then finally, I think there's a role here for the federal government to think about braiding and blending funding. So particularly for our Medicaid population, they are touched by a number of federal and state agencies in terms of HRSA, SAMHSA, the CDC, maybe at a state level, people are on food assistance. And so how do we bring both the information together and the payment together to get people the services that they need? I think there are some really big barriers into doing this, and certainly mentioned today is lack of transparency. So thinking about how we share data on health outcomes, on quality, on cost, on patient and provider experience will help us understand what we're doing now and how we can make it better. I think our health systems right now are very hospital-centric, and we need to move to be a bit more community-centric and think about how do we help people in what we have right now is very complicated siloed care. How do we help people find the care that they need? That being said, I think that there's a lot of great conversation going on, and having that conversation helps build trust to move to the next level. I think there are things we can do to create a will for providers to change. As we started out talking about COVID, there's a lot of clinician burnout. COVID has been very hard, and I think people want to change and people want to provide the best care, but that's really hard and they need hope. And I think we can give them hope by engaging a variety of stakeholders, which includes clinicians, payers, also employers who are paying for their employees' benefits, state and federal governments, and I would say most importantly, people who are getting the care and experiencing that. And I think working together and collaborating, and maybe I'll say holding hands and jumping together is a way that we can move forward and make a real difference. I think now is a critical time to do that. And so let's go.
Well, thank you, Judy. Eric?
Thank you, Jim. Very much appreciate the opportunity to be with you all today and to contribute to the conversation. To your earlier question, there was a lot that resonated today. I think, as I share just a couple of my thoughts and reflections, I think you'll hear some similar themes. I've had the fortunate opportunity to wrestle with the question of practical action to advance alternative payment models, really from three very different perspectives. First, from a policy perspective, working at the Center for Medicare and Medicaid Innovation. Second, from the perspective of at-risk providers, where I was working in support of providers as an operational partner to help them be successful in value-based arrangements. And then now in my current role from the perspective of a commercial payer, trying to not only move more of my network contracts into value-based models, but also really to increase the impact and sustainability of those models at the same time. So I just thought I'd share really a couple of reflections from each of those three different, very different experiences. At Cmmi, we were also certainly looking at things from a payer perspective with CMS, sorry, as the largest payer. However, we were also, I think, trying to carry forward the policy objectives established by the Affordable Care Act, which meant we needed successful, scalable payment models that also made the case for the policy and regulatory changes that would support them. Some of the things that we wrestled with, and these are just my observations. One of them was what I would refer to as the alignment between the policy goals and the provider's business goals. And at the risk of oversimplifying or overgeneralizing, I felt like there was broad agreement on the clinical objective, the triple aim, the need to improve outcomes while lowering cost. However, the practical challenges were really around the question of how. Could we agree on the best way to measure success? If so, could we agree on the appropriate reward structure? If so, could that reward be substantial enough? And I know this point was made earlier, substantial enough to really justify the risk and investment providers would need to make in order to make the model itself successful. I think that's one of the reasons, just from a practical perspective, you saw significant iteration on things like population attribution, quality measures, and data sharing. And I think in all these cases, what we're trying to do was to get, in order to get adoption of the models, was find ways for us to make it easy for providers to participate and make the path to success as easy to understand and to navigate as possible. In some cases, it's more easily done than in others, but that's where a lot of the rubber met the road in terms of trying to get into the tactical elements of design so that you could make the participation easy. I'd say the second main observation from that time for me was just the alignment of policy goals to what I would call business realities. I remember, in the early days of the development of the first bundled payment for care improvement model, the idea of the convener in the model emerged. And I remember thinking at the time that it made sense that in order for all the parties to be aligned, someone really needed to play the role of holding everybody accountable and distributing the funds and all those things. But I also remember thinking, just from my own experience, I remember thinking that from a pure business perspective, that job didn't naturally exist out in the world. And there may or may not be the systems there to support it. Think accounting, reporting, like in the way that we would envision it in the future of that model. Now, we were creating an incentive for those things to emerge, and they did, but it stuck with me, and it still sticks with me, how important these kind of mechanical things are to the success and the adoption of these models, and how we really need to take into account the operational solutions that exist or that don't exist, and think about how do we bring them to bear. And then the last one quickly was just the observation that, and the reality that we were, I think, running into every day was the provider's need for infrastructure and capability. And just for context, this was at the very beginning of, I was at Cmmi right at the beginning. And, a lot of those conversations that we had with providers around the things we were designing, the theme of it was things like, to be successful in the models and to move away from fee for service in the long run, they needed capabilities they didn't necessarily have at the time. They didn't necessarily have people to connect with patients when they left the office, or analytics to tell them who they should be bringing into the office. And it was actually that question that really led to my next adventure, where I was working with at-risk providers. And I had an opportunity to work with an organization. We were supporting health systems and provider groups in taking on risk with payers, primarily starting with the Medicare shared savings and next generation ACO programs, but then moving into commercial risk-based contracts. And in this role, we tried to address some of those practical considerations, and I think a big one was just the data and the analytics and the ability to understand where the opportunities were in the population in order to be able to address, improve quality and address cost utilization. But then also seeing that there were clinical supports that were needed, programs, interventions, tested solutions that they could bring to their patients to support them in the care for the patients. And then the big one, and lastly, in this experience, was just what could we do practically to get providers in a position where they could comfortably take risk. That was a real barrier to progression. And so we made it our mission in that example to create a business model where we could comfortably share risk as a way to help providers sort of step over the threshold and get into a position where they felt like they could be successful. And I'd say the last, that kind of brings me to my last experience, which is where I am right now, sitting in the position of a payer. And all those lessons learned are kind of front and center for me as I think about our strategy. And the lesson for me practically is that accelerating movement from fee for service to value-based models means, really a couple of key things. One, and I think Jonathan said this really well this morning, is making sure we first and foremost anchor on the needs of the human being that we're trying to serve, and to be clear about the clinical objective of the model. Right? We do get very caught up on the payment model, but that's only one aspect. So we need to understand what's the impact we're trying to have and for who. And I think that's true across a whole range of applications of value-based models. And then the second, I think, is we need to focus as much on our service model as our payment model. And by service model, I mean, how do we not just share risk with the provider, but actually bring, as a payer, the assets, the capabilities, the knowledge that we have to support them in delivering outcomes for consumers. So, whether it's, again, data analytics, partnerships, or in the case of my current organization, our own care delivery capabilities as a complement to the work that providers do, whether that's utilizing the pharmacist more effectively or care delivered in the clinics, but finding ways to just really pull every lever that we have to be a supportive partner in delivering outcomes. And so for me, and I'll wrap on this, I think that the end is, the goal is really marrying this combination of the right clinical objective, the right focus on the human impact we hope to have, the right financial model, and then the right support model. And I think if we can find ways to do those things, we can accelerate adoption, because inherently it better aligns and makes it easier for the provider to participate and see the path to success. So thank you again. Really appreciate the opportunity to be here.
David, Eric mentioned, one of the issues being how to operationalize a model and, make it work according to its intent. And Cindy Mann mentioned earlier that there can be a disconnect. The hierarchy in an organization thinks that, they're doing a value-based model. But if you look at the individual providers, they're being paid basically fee-for-service equivalent. And in some of our own surveys, we see this disconnect between those two levels. So what do you think about, is this something that you've encountered? And how do you think about that?
Yeah, Jim, you're hitting on a critical point. I talked to dozens of my colleagues across the country that run large health systems, and I can tell you that they would all totally agree with everything that's been said today. The problem is, how and why would they move their business model? When I talk to most of my colleagues and ask them, what % of your revenue is at risk? The most common answer I get is 4%. That's not going to change significantly your investments, your behaviors. And that's why at St. Luke's Health System that I ran, we built up to this in making investments and preparations to get ready for risk. But on January 1st, 2017, we moved 1/3 of our business into almost all total global capitation arrangements. I heard Judy say, let's hold hands and jump in. That's what we just jumped in. And the reason is you just can't get people's attention, and you're not going to really make a difference if you don't do that. But then the question is, why would any health system do that? And we've got to address some of the realistic concerns. The first thing is that all CEOs like myself, we have a board that we report to. That board wants us to do well. The truth of the matter is, while there are a lot of small hospitals out there that are suffering, large health systems are by and large doing pretty well. And one of the lessons that we've learned from history in all kinds of industries is that even when they see change coming, if they're doing well in their incumbent business model, they're very unlikely to make the change, even to the point we've seen prominent companies we know go bankrupt or out of business. It's hard to do. And the question is, how are you going to convince your board? I took a couple years of convincing my board through different tactics that's what we need to do. And fortunately, I had a very supportive board. The other thing you're going to have to do is you're going to have to convince your leadership team. There's a very prominent health system that also agreed with all of this, decided to make the move, started making the move. Let me tell you, for them, for St. Luke's, when you make that move, your financials deteriorate. And in my case, we prepared the board for it, and fortunately, they stuck to their guns. In this other health systems example, people panicked and they reverted right back to where they were. And so there's got to be an understanding of why we should change, what that change is going to take, how long that's going to take, and what's going to happen, and that your performance is going to suffer initially if you do it at a significant amount of risk like we did. The other thing is, we have to look at what people's incentives are. If you look at most incentive structures among leadership at health systems, those people are going to have 30 or 40% of their compensation at risk. They are not going to do this and give up that compensation. We were very fortunate at my health system that the board was very insightful and said, we're not going to have a bonus in structure. You're either going to do your job and you get to keep your job, or you're not going to do your job and you lose your job, but we're not going to do a bonus so that you can focus on what's the right thing. And that's what enabled us to do that. And so you have to make that change. The other thing that we have to recognize is that a lot of health systems are not systems. Mine wasn't when I got there. It was a confederation. And that's the first thing I had to address is how are we going to act like a system? And that takes a significant effort, and we did it, but it's painful and it takes some work. And then the next thing that we focused so that I could get everybody moving in the right direction and prepared for taking risk was we focused on quality. Our health system wasn't even the quality leader in our market when I got there. And I told the board, if you hire me, I'll make you a national quality leader in 5 years. If that's what you want. And they did, and we did, and we worked on it. And then by every measure you can imagine, we in fact made that. And what that did was allowed us to work on that evidence-based practices, standardized practices, because it is much harder than you think to do this. In our own health system, we traverse more than 300 miles. And frankly, a lot of the hospitals didn't want Boise, quote unquote, telling them what to do. And then unfortunately, we had a tragic outcome where a toddler died because we were doing things 2 different ways. And that was in large part a huge a communication that I was able to use to explain to people why this is no longer permissible. This isn't a matter of your pride and ego that you get to do things your own way. It's costing people's lives that could have been prevented had we done it the other way. And so that helped move us along. And then as we did that and really promoted innovation within our physicians to allow them to pursue things that would improve our performance and starting to move away from this. For example, spine surgeries. When I got to Boise, I think we were the 4th, I think the Dartmouth Atlas showed we were the 4th highest in the country in terms of spinal surgery. And I came from Texas, so I asked people, what's the deal? Is everybody hurting their backs because of mountains, or why are we doing all this surgery? And of course, we know the answer. So we put in programs to drastically change that, but you do so at the detriment of your fee-for-service revenue. And so that's the problem. If you just have if you're just dabbling in value, you're not going to make these hard decisions. And then of course, you're not going to get to where you need to go. I think Eric was just mentioning it. We can't ask the physicians to take a big a decrease in salaries either. And so you have to carefully make sure that you bring them along in a way that, again, it's a matter of just aligning all the incentives. And you know, unlike Eric's experience with payers, we didn't have a whole lot of payer support in our market to do this. But we did it anyway, and then a lot of them came along, but it does take a lot of work, and we should not underestimate what it's going to take to get hospitals, health systems, and physicians on board. It's very important. It can be done, but let's not underestimate it.
Well, thanks, David. And let me ask Judy or Eric to build on your comments. But first, you know, Judy said that there was a need for speed. You made a decision and jumped in. How long did you have to go down before you went up?
So it was very interesting. I tried to look to healthcare to figure out what the answer was. And of course, we didn't know the answer. So I actually looked at a different industry. that made this transformation, IT. And we brought in a fellow named Jeffrey Moore, who's written a book called The J Curve, and it's a very interesting read if you haven't read it. And basically what he says is, as he looked at the IT industry, that they all go through a J curve. In other words, what happens is as you begin the transformation, your financial performance declines. You then hit the bottom of the J, and then it starts coming up, and at some point you cross the line of profitability. And he said on average for the IT industry, that was about 3 years. It turned out almost exactly the same. It was about 3.5 for us to get back to profitability on this. And now, of course, as was said earlier in the day, we're really glad we made this transformation, because where a lot of providers really got hurt by COVID, actually having a third of our revenue in these global capitation arrangements actually helped preserve our financial performance.
Let me ask Judy or Eric if they would like to build on these comments.
Yeah, sure. I mean, I do think it's interesting, the 3.5 years. So we started our multi-payer table about 2 years ago, and I think it's going to be right around 3 years or so, 3.5 when we get to implementation. So I think that, there are definitely conversations that need to be had. There needs to be trust built. The financial incentives are often every which way, and people think they're doing a good job, and they want to be doing a good job. So why would they change? And so showing people how it can be even better, I think is part of that key. And at one point in the middle of the COVID pandemic, I think I was hopeful that more people would make this leap, because we've been sort of 1 foot on the dock, 1 foot on the boat of VBP for a while. And the dock definitely sunk in the fee-for-service sort of way. And so I thought people would jump on the VBP train, but the dock sort of stabilized and came back up. And maybe it's a little bit underwater, but the dock of fee-for-service is still there. And so figuring out how you chart this course into a new way of delivering care, I think is hard. And we've shown it can be done. I think that the change to telehealth, we had been encouraging telehealth for a few years with like zero movement by providers. And suddenly when in-person isn't there, we helped some small providers buy Zoom licenses and things like that. But people switch very quickly to being able to deliver telehealth. And now that's not going away. And that's fantastic. So we can deliver care differently, but you sometimes need a little push to help get you there. Eric?
Yeah, no, one of the things that jumped out, I think the concept Judy talked about of needing to, the need for speed. But then David, also you talked about not underestimating the time that it takes to really get adoption. I think it's important to think about those two concepts need to live together. And so I think where the need for speed comes in is in the adoption to get in the, get into the game and start the process of what David, you rightly pointed out, is a change management exercise that takes time. And so when I think about that experience of working with providers, as that operational partner, our efforts were, how do we knock down the barriers to getting in? How do we make it easy for them to take risk? How do we give them capabilities to make them confident? But even with that, we knew that and experience bore out, it would be over the course of a couple of years that even as a vendor to them or a partner to them, we would need to earn their trust, with the data we were bringing them, with the solutions we were bringing to them. The leadership of the system would need to build trust with the providers that they were all on the right path together. So, but I thought it was those two things, need for speed and long change management exercise are not mutually exclusive. They both are things we need to keep in mind. I think in this journey.
Eric, you mentioned you used the term service model as in addition to the payment model. Are they two dimensions of the same thing? Does one come before the other?
That's a great question. I think at least in my head, they have to be related. So if we think about what the objective of whatever the payment model is, and then we think about the right the right payment model, the right way to construct the financial arrangement to support that objective. Then the question, the service model is, what is it the provider needs to be successful in that model? And that's where we start to array the services. So, if it's a primary care based model where you're trying to impact the broad population, we can think about some discrete things the provider needs and whether or not we can help them. Can we help them better understand the patients they should be engaging but aren't engaging? That's part of the service model. Can we help them understand what's happening in terms of cost and utilization outside of the walls of the primary care practice? Are there capabilities to help them better understand that and influence that? So that would be different than, I think, some of the services we attach to a bundled payment model, or some of the newer applications that we're seeing around these focused clinical models in the market, where they're looking at a specific need, like, for example, chronic kidney disease, a specific group of patients with a specific condition, and then try to create a model around it. That would require a whole different set of services. So, sorry, long answer to the question, but I really think they all have to live together, because the services have to be tied to, the things that the provider needs to be successful in that model to deliver on that clinical objective.
So
hopefully that helps.
Yes, as a thought experiment of a kind, the three of you are my board. I've just taken a job as the CEO of a system that is embedded historically in fee-for-service, and want to move that in a different direction. And I asked my board, the three of you, what are the first three most important things that one has to deal with and do, and what actions have to be taken?
Well, I could start because I actually did this. So I think the first thing is, and as I talk to my colleagues, what I think is holding people back is, I think you need a worldview. Do you think fee-for-service is going to be here for the next, whatever your career time horizon is, Jim? If you're going to take this job for 10 years, do you think we're going to be in value by then? Do you think we're still going to be in fee-for-service? Board, what do you think? And, frankly, I used, when I got to St. Luke's, it was 6 months before the passage of the Affordable Care Act. We didn't know if it was going to be passed or not at that time. It was very contentious, but I told the board, this is one of the signs. The very fact that Congress feels they need to pass a new law about how the healthcare system behaves means that this is something that's going to get addressed. If not the Affordable Care Act, something else. So do we want to take the lead, or do we want Washington to tell us how to do this? Another thing that you have to do, I really liked Eric's comments just a minute ago. One of our competitors, I was talking with a doctor there, and he says, the problem according to him he said, we can't change the clinical model until we change the reimbursement model. We can't change the reimbursement model till we change the clinical model. So he was, and I think like a lot of people, just holding up their hands going, it's a no-win. We can't do this. And in fact, it's a false dichotomy. You have to do both at the same time, which is what we did. And I think so in informing the board, you have to talk about what is your worldview? What do you think is going to happen under fee-for-service? And I think that you need to look at what's been happening to your fee-for-service reimbursements historically. There's probably not that many areas where they've been going up. What's happening to your costs? We showed the board a cross-section of declining reimbursements, increasing costs, and at some point, you're going to become negative. My argument to the board was, if we're going to make this transformation, if we believe the world is moving to a value-based arrangement, don't we want to do it while we still have this margin that can support the early losses? Do you really want to wait until you're losing money in fee-for-service and then have to try to make this transition? So I think that was an important argument. One other point that I think, and then I'll stop, that Eric made that I want to reinforce was this issue about changing the model. Realize that even for us, even though it was a huge change to put a third of our revenue at full risk. That was $1 billion at full global capitated risk. Even doing that, that meant 2/3 was still in fee for service. And if you try, and another thing I learned from studying other industries, if you try to have the same people do both, they will sabotage the new model because they want to preserve the older. So what I set up a separate subsidiary. I set up a leader in that organization that all he was to do from the moment he woke up to the moment he went to sleep is think about value. And don't for 1 minute think about fee for service. Then over in the health system, I had plenty of people thinking about fee for service. So, but that was his job. And I kept them as isolated as I could. And then I told them, you tell me what you need to do. I had them report to me, not our CFO. And because I didn't want to allow them to be overruled, I want them to keep driving it forward.
Thanks, David. Let me ask in the last minute or two if Judy or Eric would want to build on that.
Sure.
Yeah, go ahead, Eric.
Well, I would just say David's point about leadership alignment and a aligned worldview. You could almost argue as points 1, 2, and 3. That's really the important thing. I think the other thing, and David, you mentioned this earlier in your comments. This idea of, if you think about what we're doing in value-based models, we're realigning incentives for providers. Well, from a systems perspective, once you make the decision to go down that road, looking at the natural incentives that exist for the people you expect to execute on that vision is another really important thing. So that the internal incentive structure and the operational structure, like David just mentioned, is all aligned. And then the only other thing I would add would be understanding what investments you need to make in order to be successful in those value-based models, whether it's analytics, whether it's clinical capabilities. Many of the systems I've worked with, it wasn't that they didn't have them, but they weren't necessarily aligned around producing results in a value-based model. And so there are some examples where they made the hard decision to consolidate resources, to refocus them on different tasks. But there are investments that are needed, and I think that's probably the important third action.
Judy?
So I'll jump in and I'll say, how can we be the best? I think both boards and physicians are very competitive and, see a need for collaboration. So as Mai said, sort of how do we build on that competition, collaboration, push-pull? I think thinking about the need for value, and in particular, thinking about your own care, I've certainly experienced it of like, no, you need to come back in. No, you need to come back in. I don't need to come back in. Just order this test for me, please. Like, okay, that's how you get paid. So I guess I'll come back in because otherwise you wouldn't get paid. But there are a lot of things that, I'd rather stay at home and do a virtual visit or stay at home and just go to a lab and get what I need rather than having this back and forth. And I think now with COVID, we can understand that we can think beyond the four walls of the health system to think about how care is delivered. And so we should move in that direction. And then using my big stick, mandatory models are coming from the state and the federal government. And so, yes, do you want to figure out what works best for you on your own, or do you want to have to be shoehorned into what it's going to be? And so I think being part of the solution is always attractive. So thanks.
Well, thanks. This was really a great conversation around the practicalities of doing something that's really worthwhile. And, the lesson I'm taking is that it takes alignment and full commitment because it's hard to do. And the three of you really outlined that in a beautiful way. And going back earlier in the day, when Jonathan Bloom was talking, I thought it was compelling, his projection of CMS focusing a little more on the goal rather than getting into this technocratic aspect of the perfect model, to think about the goal as the yardstick of going forward. And then hearing from the sector impact assessments, the alignment between, three different lenses looking at the same thing whether it be, collaboration, coordination, or the importance of health disparities and getting to a more equitable position. And when you think about it, it's almost definitionally impossible to get the optimal outcomes and optimal value and optimal safety if you haven't leveled the field in equity. And that is, really going to be critical. We heard that also expressed, I have to say, in the discussion of the current academy initiatives. And I think the three of you brought it home in a very nice way with sort of the practicalities of folks that have done it and the barriers you've run up against. So this has been a fantastic program. I want to thank everyone for participating. And at this point, hand it to Michael for the close.
Well, thank you very much, Jim, and thanks as well to all the presenters, the reactors, and the attendees. You offered a really cogent and crisp summary of some of the key take-home lessons that we've heard in the course of the day. It's been an extraordinary set of conversations, extraordinary in its richness of the issues that were engaged, their breadth and their depth, but also extraordinary because the spirit throughout each of them had a resonance one to the other. So it does bode well, I believe, at least for our capturing this moment of opportunity. And the lessons that have coursed throughout the conversation will try to gather. They're take-home lessons not only for us to take home to our own institutions, but to take to Capitol buildings in Washington and throughout the states, and to take to our boardrooms. And it's our job now to be as crisp as we can in summarizing those insights and making them available. I, of course, want to give, in particular, thanks to you, Jim, and to Susan, for the dedication that you both have brought to accelerating value in population health, into your leadership of the Action Collaborative, to be continued. And also, thanks to the staff of the Leadership Consortium, who will be summarizing those take-home lessons and who produced this wonderful meeting. And I'll just mention their names briefly. Ayadola Nishe, who's the Deputy Director of the Consortium. Jennifer Lee, Visiting Scholar. Olivia Matongo, who's the Program Officer. Ariana Bailey, who's the Senior Program Assistant. Mike Cocciola, who's a Research Associate. Each and every one of them played a wonderful and hard-working role in setting the stage for what our presenters and reactors and chairs have done in the meeting. We very much look forward to the follow-up, as is always the case, but especially in this particular case, the agenda remains open. Please do use electronic methods to follow up with any questions or suggestions you have, and we're going to try to take full advantage of the creativity that was creativity and expertise that was expressed today. So thanks very much. To be continued. Be well, stay safe, and we'll look forward to the follow-up. Enjoy.